All right, good morning. Good morning, everyone, and welcome to the Mental Health Services Oversight and Accountability Commission meeting. My name is Mara Madrigal Weiss, and I am the chair of the commission. I want to thank you for attending today's meeting. Before we get started today, I am happy to announce that the commission has a new chief counsel, Ms. Sandra Gallardo, is our new chief counsel. Sandra joins us after nearly a decade serving students at Sacramento State as the executive director of a nonprofit auxiliary corporation. Prior to her role at Sac State, Sandra served as assistant secretary at the California Health and Human Services Agency, where she worked as a liaison to the commission and participated in commission meetings and site visits. Sandra earned her law degree from UC Berkeley School of Law and her master's in public administration from Harvard Kennedy School. Residing in Sacramento with her husband and child, Marcelo, Sandra is an avid reader and knitter, and on her time off, you can find her supporting her child's goals of earning an Eagle Scout ranking in Scouts. Sandra, welcome to the commission. If you'd like to share a few words with us, please.
Hi, everybody, and thank you so much for the kind words, Chair. I am very excited to be back with the Commission. It's been about 7-8 years since I served as the agency liaison, and it's so fun to be back and help support the Commission in all of its many, many projects. Thank you.
Thank you. So if we can have a round of applause, we're so happy to have her here. Thank you. Since Jeff Margolis's passing in November, Maureen Riley has supported the commission as interim chief counsel as we work to fill the gap left by Jeff's passing. Please join me in thanking Maureen for her support over these past few months. Maureen, if you could please stand. Thank you, Maureen. At our January 25th commission meeting, we approved the commission's strategic plan for 2024 through 2027. Cody, can you please bring up the strategic goals slide? This slide reflects the goals of the commission's new strategic plan. This plan continues our commitment to the advancing of commission's vision of well-being for all Californians. While the content of our meetings often touch many of the strategic plan goals, today we will be discussing the implementation of Prop 1, the changing rules for full-service partnerships, and how the Commission can support the state's efforts around behavioral health reform. These topics are directly connected to our strategic plan goals of championing vision into action and relentlessly driving expectations. You may also notice that many of the agenda items have icons next to the titles. These icons represent the strategic plan goals associated with each agenda item. Thank you, Cody. Now we will take roll and establish a quorum. We would like to note for the record that we currently have a quorum of 8 commissioners in person. As some of you may notice, we have 1 vacancy on the commission and 1 commissioner currently on leave. Therefore, under the Bagley-Keene Open Meetings Act, 8 commissioners are needed for us to conduct business today. Sandra, can you please take the roll?
Chair, let's skip to announcements since we are waiting for 1 more commissioner to make quorum.
Absolutely, thank you. We will move on to agenda item 2 then. I would like to begin this morning's announcements by recognizing that May is Mental Health Awareness Month. Since its inception in 1949, Mental Health Awareness Month has been a cornerstone of addressing the challenges faced by millions of Americans living with mental health conditions. This national movement is dedicated to eradicating stigma, extending support, fostering public education, and advocating for policies that prioritize the well-being of individuals and families affected by mental illness. Across the state, there have been multiple events held to provide and bring attention to those facing mental illness and recognize the importance of access to mental health services for all Californians. Some of our commission staff participated in the mental health awareness activities held at the Capitol last week, highlighting the Commission's work to transform the behavioral health system. We commissioners want to thank you all for your diligent work on behalf of this Commission in continuing our commitment to reduce stigma and the adverse outcomes of mental illness and promoting the mental well-being of all Californians. I am also happy to announce that the Association of California State Employees with Disabilities has selected the Commission as the recipient of the 2023 ACSED ACES Award for Small Departments. This marks the second consecutive year that the Commission has received this award, which recognizes a department's outstanding contributions to advancing disability employment within state government. Congratulations are due to the work of the Commission's HR staff in reducing barriers to state employment and helping to create an environment that supports and uplifts individuals with disabilities. These individuals bring a wealth of unique talents, skills, and perspectives to our organization. This award not only acknowledges our past achievements, but also serves as a reminder of the work that lies ahead. The Commission is growing, and in addition to our new Chief Counsel, we have other new staff to welcome to the Commission. I'd like to invite Ryan Kopchak to the podium to introduce our newest staff member.
Thank you, Chair. Good morning, Chair, Vice Chair, and Commissioners. It is my pleasure to introduce to you our new Assistant Chief of Community Engagement and Grants, Daniel Fisher. Danny joins MOSAC from the Department of State Hospitals, where she worked for 8 years managing the statewide wait list and implemented programs throughout the state for patients committed to the Department for competency treatment. During her time at the Department of State Hospitals, Danny played a lead role in ensuring that every patient was placed at the most appropriate facility based on their individual needs. Prior to working for state hospitals, she worked in the private sector for 4 years, advocating for patients in the Grievances and Appeals Department at Anthem Blue Cross Blue Shield. She received her bachelor's degree in communication studies with emphasis in public relations from California State University, Sacramento, and she brings with her a passion and excitement for mental health awareness to the Commission. Thank you.
Hi, I just want to say I'm very excited to be here and I look forward to working with each and every one of you. Thank you.
Welcome, Danny. We look forward to working with you. On to other announcements. The April 25th Commission meeting recording is now available on our website. And last week, the legislature considered all legislation with a fiscal impact. With the current budget deficit, many bills unfortunately did not pass. However, I am happy to report that 4 bills the Commission supported did pass, including AB 2161 on early psychosis intervention, AB 2352 on psychiatric advance directives, AB 2711 on a public health approach to suspensions in schools, and SB 1318 related to youth crisis responses in schools. Unfortunately, AB 2411, our sponsored bill by Assembly Member and Commissioner Carrillo, and SB 1472 created a voluntary do not sell list for firearms did not move forward. We look forward to pursuing these important issues in the future. I'm also happy to announce that the Commission's Client and Family Leadership Committee and the Cultural and Linguistic Competency Committee held their first meetings earlier this month. Under the leadership of Commissioner Chambers and Commission Vice Chair Alvarez, committees have the enhanced role of supporting the implementation of the Commission's strategic goals and objectives. I would now like to invite Vice Chair Alvarez and Commissioner Chambers to share updates regarding their first held meetings. Vice Chair Alvarez, if we could begin with you, please.
Sure, absolutely. Thank you, Chair Madrigal-Weiss, and good morning, everyone. We are excited to share that the CFLC and the CLCC met jointly on May 8th to discuss the strategic plan and in particular the work that we want to undertake in support of the Commission and of our work as a state to go through the modernization process under implementation of Prop 1. I think one of the things we've discussed a lot of as a Commission and with our committee is the opportunity to leverage the expertise and experience of our committee members. And this meeting really helped begin that process, particularly under the direction of our new strategic plan. We were grateful to see everyone's commitment to the work continuing. I want to be clear that there are some vacancies in our committees due to some shifting job responsibilities by our committee members, but I'm excited to report that more than half of our members have indicated that they're able to stay on the committee through the end of their term in June 2025. From this point on, we expect that the CLCC and the CFLC will meet separately, with the CLCC focusing our attention on how the strategic plan addresses the needs of our marginalized, our underserved communities, But I want to be clear that this conversation and bringing together both of these committees was a powerful indicator of the intersection of so many challenges between clients and family members and marginalized communities, recognizing that many times these are the same communities that we're advocating on behalf of. So we are exploring bringing together the committees again for a joint meeting in the future. I'll hand it over to Commissioner Chambers.
Thank you, Commissioner Alvarez, and I just want to acknowledge just the synergies that both committees had and the intersection between culture, family, consumers. There's a strong intersection, and I'm looking forward to having more joint meetings in the future. But specifically, Deputy Director Norma Pete, during our committee meeting, gave an overview of the strategic plan, and it was followed by a robust conversation about how to really engage people on the ground doing the work, because we believe that still there's a lot of work to be done with, getting the input of folks on the ground. The committee members and the public discussed the importance of being able to reach folks who haven't been reached, as well as elevate the diverse perspectives of those communities. The conversations focused also simultaneously on how to utilize traditional matrix and while transforming and amending those matrix in ways to better capture the work on the ground. And I think that that's profound, because I think that that's a lot of the conversations now, even with Prop 1, and how do we have accountability and use matrix to capture, like, are we even capturing people's voice? So I think that's something that we're going to be working on. So all in the name of supporting the commission and the strategic plan. All of our work will align with the strategic plan. And as a part of this conversation, the group discussed the importance of community engagement, how it should be defined, how to incentivize the work, because the community is already working. How do we not tire them down, but really capture their voice? The committees are committed to identifying how the commission identifies the small wins in the midst of all this, and doing the work that meets the definition of the impact of the work that we're trying to achieve and the wins for our community. I'll hand it back to Commissioner Alvarez to close out the conversation.
Thanks, Commissioner Chambers. And just really want to emphasize Commissioner Chambers' comments about how the conversation really helped, I think, challenge how you measure progress, how you measure accountability. And we couldn't ask for a better group of folks to think through that than our CFLC and our CLCC members. So huge appreciation to them. So the committees are planning to meet every 2 months, given that the first meeting was later on in the year. The CLCC is planning to meet on June 12th, and the CFLC is going to meet in either July or August, but looking like July 17th. Meeting dates and times will be announced in the coming days. And again, huge thanks to our committee members and to our commissioners. Commissioner Rolette, thank you for being with us, and looking forward to continuing the conversation.
I want to thank you both for your leadership and commitment to this work. I recently heard a podcast from Dr. Jeff Andrade Duncan. He's one of my heroes in education. And to your comment on measurement, we measure what we treasure. So I think we need to definitely continue to work towards this. So thank you both. I appreciate that. Since 2012, the Commission has supported Art with Impact's mission of promoting mental wellness by creating space for young people to learn and connect on mental health themes through art media. In addition to their arts-based workshops for college students, Art with Impact has built the largest and most diverse collection of mental health themed short films in the world through their annual film production grant program, which funds 10 filmmakers each year to create short films on underrepresented mental health narratives. Space is limited, but it is still available for commissioners to attend this year's premier film festival, Voices with Impact, in person at the San Francisco LGBT Center on June 6th at 6:30. So please contact staff if you would like to attend. If you can't, you can also join in person. If you can't join us in person, you can register to attend online. And finally, I am excited to share that based on feedback from our community engagement with transitional aged youth, the Commission will pursue the development of a podcast. The focus will be on highlighting the Commission's portfolio, particularly new and exciting mental health projects that may impact transitional aged youth. This new communications channel will support the Commission's strategic plan goals of elevating the perspective of diverse communities, disseminating learnings from innovation and best practices, and growing public interest and awareness in the Commission's mission. I want to welcome everyone again to today's meeting. The plan is to end around 4 p.m. Commissioners who are online, if you leave the teleconference meeting for any reason and decide to rejoin, please make sure to use the raise hand function so the Commission staff can make you a co-host. It is now time for we are going to go back to roll call. Thank you. So Sandra, please.
Good morning. Bontrager. Brown.
Here.
Bunch. Here. Carrillo. Carnevale.
Here.
Chambers.
Present.
Cortese. Danovich.
Here.
Gordon.
Here.
Mitchell. Robinson. Rolette.
Present.
Alvarez.
Here.
Madrigal Weiss.
Here.
Chair, we have quorum.
Thank you. Now it is time for Agenda Item 3, General Public Comment. This time is reserved for comments on items that are not on the agenda. I want to note that for individuals providing public comment on Zoom, you will see a small timer in the upper right-hand corner of your screen. This timer will let you know how much time you have left for public comment. If anyone is interested in making public comment regarding the announcements or other items, please make those during this general public comment time. If you have any technical questions, please contact the Commission staff at 916-500-0577. At this time, I will ask Amariani to go over the public comment procedures.
All members of the public will have the opportunity to offer comment as described in the agenda. If you would like to comment on an agenda item, please wait until that item starts. You may request to make public comment by clicking the raise hand icon on your computer or the app, or if calling in by phone, push *9. You will be placed in a queue to comment on that agenda item. When it is your turn to comment, the moderator will unmute your line and announce your name or the last 3 digits of your telephone number. When you are unmuted, we are able to hear you. We will do our best to take comments in the order they are received. Please note, once the public comment period for the agenda item starts, we will close the public comment queue, so please make requests to comment now. The moderator will insert the word last comment next to the commenter's name or number to identify the last public comment. Members of the public should be prepared to complete their comments within 3 minutes or less, depending on time constraints. When we have reached the end of our time, our staff will let you know, but we will let you finish your thoughts. We don't mean to cut you off, but we do want to help everyone keep time. We truly appreciate your understanding with this process. Lastly, if there are any members of the public using translation technology, please notify the chair, and at least twice the amount of time will be given to you during public comment period. A live meeting transcription or closed captioning is available for anyone participating in the meeting. If that option is not currently visible, please activate the closed captioning feature located in the control bar at the top or bottom of your screen. We currently have 3 public comments online. The first public comment we have is from Hector. Hector, your line is open.
Can you hear me?
Yes, we can, Hector. Please go ahead.
Good morning. I'm using captioning service and sign language services, so it takes me a couple of seconds to respond. Good morning. Yate. My name is Hector Ramirez. By pronunciation, them. I live in Los Angeles County in the unceded lands of the San Gabrielino Band of Mission Indians. I'm a person with a disability. I am autistic, hard of hearing. I have long COVID, and I'm a DV survivor. But most importantly, I'm a person with a psychiatric disability, not a mental illness. And so I really want to reiterate the need to really have trauma-informed practices and culturally responsive language in these spaces. As a person with a disability, psychiatric disability, the language that we use is very important so that it doesn't further traumatize and stigmatize people, particularly our young ones who listen to these conversations and oftentimes come away feeling worse about themselves, having been described as mentally ill. And that type of language contributes both to the despair and suicidality that our young people face. And I really hope that this commission listens closely to that so that it stops and really be conscious about the way in which they interact with the community so that they don't further traumatize and harm the people that are coming here for help, like myself. I am a consumer of Los Angeles County Department of Mental Health. And first, I want to really thank this opportunity and really reiterate the need to ensure that as you continue doing your work and evaluating the proposals from counties like mine, that you really look closely at how accessibility has been implemented in the way that stakeholders have an opportunity to interact with counties in developing their plans. As you go on to develop metrics and procedures to really focus on accountability. As somebody who's very active both at the county and the state level with MHSA processes, I'm very disappointed that Los Angeles County really failed to provide the needed and requested disability accommodations for my peers to be able to access the meetings in which these discussions took place, to be able to access the materials in the necessary and requested disability format that we needed to access them. And not having had the opportunity to do that, we haven't even been able to review or evaluate the current 2-year MHSA recommendation that the department and the commissioners presented to our board of supervisors. The material is not accessible to people with disabilities. It has pictures of documents. It doesn't have descriptions. When we requested the material, we were simply told that the material was available in large format, and that was it. That's unacceptable. It's not in compliance both with county, state, and federal regulations requiring accessibility to county and state processes. We have new disability laws at the state level because of these issues that we've had. And so moving forward and with your new council, we really urge to really align and become aware of those particular statutory codes that are both at the state level and at the federal level. California has the largest collection of disability laws, but unfortunately a lack of oversight and accountability of them means that they just sit on the shelves while my peers struggle to get the services that we need. And I'm really glad to see Dr. Sharon here, because I never thought I would actually say it, but all the accessibility work that he did during his time has disappeared. And I really want to commend because he helped to advance a lot of that. And with him having been removed, it has become aware that a lot of the work that he was doing really had been sabotaged by a lot of the staff who are currently running the systems. And that is a significant point of concern, particularly as we move from Mental Health Services Act into Prop 1. We want to make sure that the same mistakes that were in the system don't continue to perpetuate and harm our communities. Thank you, and I look forward to working with all of you. And the visual description in my background is the disability pride flag, which is very similar to our LGBTQ pride flag, but it's particularly for our disability community. And in it, it has an intersection of colors, and psychiatric disabilities as an unapparent disability is very much highlighted. I look forward to working with you and hope that as you move forward, this place truly becomes inclusive for people with disabilities, particularly psychiatric disabilities. Thank you.
Thank you, Hector.
Next, we have Vanessa. Your line is open.
Hi, thank you so much. My name is Vanessa Ramos, and I live in the greater Los Angeles area, particularly Hollywood. And I recently traveled throughout the state hosting community conversations. And there's a group of people that really stood out to me. Today, I'm requesting that the OAC spend time in the Bay Area meeting with the people connected to an organization called CERI. CERI is a Center for Empowering Refugees and Immigrants. I was also able to meet with the Korean Community Center of the East Bay. And what stood out to me about the people connected to CERI and the Korean Community Center of the East Bay is that there was a very large elder population. And as we were having dialogue, one of their main concerns were that, due to funding changes, that programs like Siri would be cut because that's a physical location where so many people go. So I'm open to working with the commission on strategizing on how to reach some of the populations that really get forgotten. I'm also calling for a review of the procurement processes at the county level, because one of the things that I'm noticing is that county mental health systems oftentimes have limitations that do not allow them to provide services in the way that the community best receives them. And when I've asked on why they're not contracting some of those services out, one of the things that I've learned about is the stringent procurement processes. And I just feel with so many changes going on, I really hope that not even hope, I'm requesting that the OAC spend time and even create a subgroup that focuses specifically on the procurement process to ensure that peer-run organizations that are truly peer-run, delivering authentic, pure services, aren't limited in access to some of the contracts that may be out. Because at this point, I'm seeing an influx of out-of-state, out-of-country providers coming into California, taking up a lot of huge contracts that could be best delivered by Californians. So I honor the time and thank you so much. I'll put my information in the chat and I do hope a response back. Thank you.
Thank you, Vanessa.
Our next comment is from Stacy. Your line is open.
Good morning, Commissioners. Stacy Hiramoto with REMCO, the Racial and Ethnic Mental Health Disparities Coalition. I just want to say I was able to be at a presentation at the Center for Empowering Refugees and Immigrants that Vanessa presented, and it was very well received. And so if you could I just want to second her comments. But the main reason I wanted to speak is to tell you that I had a delightful meet and greet with your Chief of Innovation and Programs Operations, Jigna Shah, just a couple days ago. It was just a meet and greet. I think she was a wonderful addition to your staff. But I did tell her that we were looking in the community to see whether an innovations committee could be formed, as the commission now has such a big responsibility for Prop 1, the innovations component. And I'm very happy that you have that. And I think you will do a good job, but I really believe you need a committee to advise you. One of the reasons, of course, is that I have been telling people, REMCO has been saying that the second best opportunity after the prevention component that is being handled by the Department of Public Health, the second best opportunity to get CDEPS funded, frankly, is through the innovations dollars that you will be in charge of. So that's why we're interested. Also, in the governor's May revise, he cut the CYBHI, the Children and Youth Behavioral Health Initiative, quite a bit, but unfortunately, he cut the components that he cut are the ones that fund CDEPS and that serve the LGBTQ and BIPOC communities. Of course, those cuts are not finalized because we are pleading with the legislature, who seems to be very supportive of our concerns. So we don't know. I know something has to be cut. I realize there's a deficit. But again, I feel like services for BIPOC and LGBT communities, they're last to be funded and first to be cut. And sort of like, first hired, last hired, first fired. It's the those services and programs that serve us, our communities, are last funded and first cut. So anyway, thank you. We're really looking forward to working with you on innovations. Thank you.
Thank you, Stacy.
And that was our last public comment.
Thank you, Mariani. The commission will now move to agenda item 4 and consider approval of the minutes from the April 25th, 2024 commission meeting. At this time, I would like to invite commissioners to offer comments or ask questions. Please, Commissioner Brown.
Could I just get one very slight correction on page excuse me. Page 2, the last paragraph, second to the last sentence, where it says staff to client ratio, that should be inverted, to client to staff ratio.
Thank you, Commissioner Brown. Staff have taken note of that. Any other questions or comments from commissioners? Seeing none in the room or online, we will move to public comment. Mariani, please raise your hand now as the queue will be closing. Mariani, do we have any public comments on this agenda item?
We have no public comments on this item.
Thank you. I would then ask to entertain a motion that the commission approves the April 25th commission meeting minutes, and we have noted your request of change, Commissioner Brown. Thank you, Commissioner Brown. Do I have a second? Commissioner Carnevale? Thank you, Commissioner Carnevale. We have a motion and a second to approve the April meeting minutes. There were no questions or comments, so then I'm going to ask Sandra if you could please take the vote.
Bontrager. Brown.
Aye.
Bunch. Carnevale.
Aye.
Carrillo. Chambers.
Aye.
Cortese. Danovich. Gordon.
Aye.
Mitchell.
Sorry, this is Commissioner Danovich. Aye.
Okay. I'm sorry, Mitchell was abstain. Okay. Robinson. Roulette.
Aye.
Alvarez.
Aye.
Madrigal Weiss.
Aye.
Motion passes.
Thank you. We will be moving on to agenda item number 5 momentarily. We are a little ahead of schedule, so we are going to pause, and we are going to pause, and we will be right back as soon as our speaker gets here. So we're about 20 minutes ahead of schedule, so we will pause momentarily. Welcome back, everyone. For agenda item 5, we will be focusing on the transformational change in behavioral health with a panel on full-service partnerships. As you may remember, we heard a presentation in April of last year about the history and promise of FSPs and heard an overview of the efforts to establish best practices for the model. Our goal with today's panel is to continue the conversation around the Commission's efforts to drive improvements in FSP service delivery and opportunities that behavioral health transformation establishes for FSPs. We also want to discuss how the Commission can be a collaborative partner for FSPs. We'd like to welcome Emily Melnick from Third Sector, Richard Johnson, and John Sharon from the Healthy Brains Global Initiative, and Susan Holt from Fresno County to start the discussion. We will start with Emily from the Third Sector. Emily, welcome, and please go ahead.
There we go. That's some audio. So yes, my name is Emily Melnick, and I'm presenting on behalf of my colleagues, Jason Pace, who's with me here today, and Rose Waltz-Peters, who's joining us from Boston. Want to give just a little bit of background on Third Sector. We are a national nonprofit, and we have worked with the commission for a number of years on FSPs. We do this work really with a very active lens towards racial equity and affirmatively ensuring that we're working with communities to disaggregate data, to understand disparities in outcomes and impact, to actively involve community voice and hear from folks who are impacted by services that they use, and really understand opportunities to include community voice in decision-making. And so that's the approach that we take to this work, and so just wanted to provide that background as I talk about our work on FSP. So just to share a little bit about our work, Third Sector has been supporting the commission and learning more about how to support full service partnerships across California. This particular project is a 10-month engagement where we heard from folks across the state on 3 major questions: what's working well and what barriers exist, what supports, what helps strengthen FSP, and what outcomes are important to focus on. This builds on conversations that we have had with providers across the state through this work and our support with 10 counties on multi-county innovation projects. We can just move right along. So just to talk a little bit about methodology, we conducted 3 major types of stakeholder engagement to get a strong sense of what folks were experiencing. So first we did community forums. These were large group discussions that really allowed us to hear a range of perspectives and allowed us to create opportunities for different counties to speak to and with each other. Our community forums were on strengths of FSP, opportunities for capacity building, and data and outcomes. We conducted targeted outreach. These are one-on-one and small group interviews with FSP staff, consumers, experts, and others to hear kind of individual perspectives and best practices and challenges. And then we also sent out a statewide survey, which was completed by about 225 contracted and county FSP providers. And this was really designed to help us get a landscape of the FSP providers across the state. How many providers were there? What service models are they using, et cetera. So we'll speak a little bit about what we found, but just wanted to share that background. As I said, it was important for us to hear from as much of California as possible. And we actually engaged folks from 43 of California's 58 counties. So about 3/4 of the counties were spoken to as part of our assessment process. And as you see in this chart, many counties and providers engaged in multiple formats. So participating in both a community forum and a statewide survey, et cetera. Wanted to share a little bit about who we heard from specifically. Across the 3 community forums, we spoke to 145 different people from 76 different organizations. About 45% of those that completed our demographic survey identified as people of color, and about the same proportion shared that they had personal or family experience with behavioral health challenges and the behavioral health systems in California. Through targeted outreach, we engaged 87 participants across 40 different organizations in 22 counties. Here we collected a little bit less demographic data as our focus was much more on one-on-one conversations, though the data that we do have shows that about 30% identified as folks of color and about 1/4 shared personal or family experience with behavioral health systems. And the statewide survey, we received responses, as I said, from 225 FSP programs across 35 counties, 60% of whom, about 60% of whom identified as people of color answering that survey. And the average amount of experience with FSP among survey respondents was 10 years. So we got a lot of great information about FSPs over the years. So I would love to begin just by digging into some of our findings. First and foremost, we really heard that FSPs are effective at approving a set of outcomes for consumers. We heard specifically in a recent evaluation by RAND looking at data across several counties, found that FSP contributed to improved stable housing, reduced utilization of psychiatric services, and reduced involvement with the criminal legal system in California. Consumers particularly frequently noted how FSPs help them access benefits, find stability supports, and really critically build a sense of community, especially among folks who may be otherwise isolated. A couple of quotes that I'll share from our engagement. We heard FSPs provide a touchstone for someone who hasn't had one or who hasn't had one in a long time. FSPs create an alternative community for people to belong, which is an important aspect of wellness. So I want to highlight that piece, that some of the outcomes that are not always captured in the hard data about how FSPs can actually enable folks to thrive. Participants in our engagement really named the ability of FSPs to meet people where they are and the flexibility of the model to provide needed supports as major strengths of the model. Some other quotes I'll share. From a community forum participant, we heard, some of the best parts of FSP are related to our ability to join with the client wherever they may be. We make great connections with humans in need. FSPs are doing, this is another quote, FSPs are doing work that matches the values of MHSA, creative, flexible dollars for barrier removal and creative treatment. Lastly, and I think most powerfully, FSPs create conditions to live with more dignity, to be housed, to transgress barriers, to have a soft landing and an abundance of resources. FSPs give people their own voice and connect them back to families. So we heard that overwhelming sense of FSP's strengths, and at the same time we heard from providers, counties, and folks across the ecosystem that there's a little bit of hunger for more clarity about what specifically is included in FSP and who's eligible for FSP services. You know, even as we heard this importance of a flexible service model and broad eligibility criteria, many providers reported challenges working through what they're calling the no wrong door policy and navigating FSP criteria to get consumers needed support. Providers shared that they'd like greater guidance on kind of determining who can be best served through FSP, who may benefit from a higher level of care, and who may actually be better served to a lower level of community-based supports. And so more support either identifying those guidelines and training FSP providers to use those guidelines to make referrals appropriately so that they're able to focus more heavily on client care and consumer care. The last thing on this slide that I'll speak to is we heard a lot about the relationship between FSP programs and the ecosystem of stability supports in which they operate. So FSPs, really rely on an ability to connect people to the services that they need to thrive, whether it's housing or substance use disorder support, ADL support, or others. That really depends on the availability of those services. And so one of our recommendations coming out of this work is to help increase availability of those other lower tier supports or basic stability supports and provide some education and resources to support connections between FSP providers and others in the behavioral health and stability ecosystem. We also heard, I'll just move on to the next slide, we also heard about the role of FSPs specifically in addressing disparities and improving outcomes for all consumers, irrespective of race, geography, or background. Culturally responsive services can really greatly improve consumers' experiences. We heard this over and over throughout our engagement, and there's a lot of energy and broad appetite to implement this. And we heard from many counties who are doing this well and are eager to share what they're doing well. Specifically, many communities have found success by partnering with community organizations, often those that provide culturally specific services, either in another language. Spanish and Asian languages came up as particularly common, or with tribal communities who provide services that are more attuned to the healing needs of folks participating in FSP. We did hear anecdotally about efforts to understand differences in FSP experience by race. However, many providers would just like some support with the data infrastructure to collect that data in a more formal way, and we'll talk a little bit more about data later on in this conversation. The last thing that I'll say, and this actually echoes one of the comments we heard today, is we did hear some challenges making sure that FSPs are accessible to folks with various disabilities, specifically mobility disabilities. Folks with mobility disabilities struggle to access FSP services or the stability services to which they are referred, particularly with the ongoing housing crisis. Many units are not accessible to folks with mobility disabilities. There's also a hunger for more American Sign Language and other captioning services for folks who have hearing disabilities. And lastly, some FSP providers talked about wanting support navigating, connecting folks to care for support with ADLs and other types of care tasks as they move forward. So one of our recommendations moving forward is just provide FSP providers with some guidance and resources around that as well. We'll move into data and outcomes. Across the board, we heard a desire to be able to use data to understand clients' well-being. Both understand clients' well-being over time and to understand how a program is doing, and to look at programs across the state to be able to tell the story of what's working in FSP. It's a lot of challenges. There's a lot of opportunity with data here and a lot of hunger to use data in a rigorous way, and a lot of challenges with the current systems, and so some opportunities for progress here. Providers and evaluators that we spoke to really shared some significant challenges with the data systems that FSP providers are using, and these are conversations that have been going on for a number of years. One piece of note is that they can be really clunky to use, require folks to enter the same information across multiple systems, and this both cuts into staff time that would otherwise be dedicated to providing direct services, and it also, frankly, can disincentivize entering data in a rigorous way. The other nuance that we heard around data systems is that given staff turnover, it can actually be quite difficult to maintain that chain of institutional knowledge, whether it's being able to look back and enter client data from several years ago, or literally understand how data systems work. So there's an opportunity for some support there. However, there is really a strong and consistent desire to use data to strengthen FSP, and we heard that there's a lack of, a common metrics across the system, which makes it hard to make apples to apples comparisons to tell the story of how FSP programs are doing, and also how individual folks are doing as they move from county to county. In addition, there's a lot of hunger to understand FSPs as a mechanism to support thriving and to build a data infrastructure that supports that as well. Currently, many providers are tracking outcomes that have to do with a lack of negative events, an avoidance of criminal justice involvement, et cetera. And there was pretty consistent hunger to add metrics related to positive events, whether it be community engagement, a sense of thriving, things like that. And so one of our recommendations is to support FSP providers to align on a set of common outcomes to track. And in our experience in multi-county and this work, 5 was the number that folks really aligned on as a good target set, but also to make sure that that set includes outcomes that are focused on positive events in consumers' lives. I will move on very briefly just to talk about funding and statewide changes, how to support FSP providers there. We found that recent kind of billing and funding changes are quite confusing and stressful for providers. Many providers reported foreseeing challenges covering the costs of some essential FSP activities, particularly outreach and community engagement. People mentioned concerns with potentially covering those given new statewide changes. Also, counties are simply overwhelmed. There's been a lot of fantastic progress and changes to FSP and behavioral health ecosystem. However, they've been concurrent, and many counties have struggled to slow down, figure out how to implement those changes in their programs. And so one of the recommendations that we have is to really help counties with some targeted support and guidance, both as they navigate these changes and as they sequence implementing changes in their own programs. The last piece that I'll name too is that providers really need some support navigating multiple funding streams that could support an individual FSP consumer, whether it's MHSA, housing dollars, or other Medicaid billing or other services as well. The last thing we'll speak to just briefly is that counties are really hungry for capacity building assistance. There was a real learning orientation from what we heard across the board, and there's many opportunities for individual counties who are doing things well to learn from each other. A lot of folks who are really hungry for peer-to-peer learning, cross-county and even within counties. The other two things that I'll kind of end with, one is really ensuring any capacity building assistance or technical assistance from the commission is really quite concrete and very specific. Folks are really interested in a directly actionable tool or guideline that they can use right now as opposed to a longer term training. And then just support pacing TA with sensitivity to capacity constraints. And just as a preview, we're planning some continued engagement to collect and share best practices for what does exist to start to facilitate some of that peer-to-peer learning. With that, I will pause and turn it over to, is it Tyler, are you next?
I believe so.
Great, thank you so much.
Thank you. So, okay. Great. All right, terrific. Thank you for your patience with the technical operations. My name is Tyler Sadwith. I'm State Medicaid Director for the California Department of Healthcare Services. I'm still getting used to saying that because for the past 2 years I served as Deputy Director for Behavioral Health at DHCS. It's my privilege to be here this morning to meet with the Commission and share information about full service partnership. I think this is an incredible opportunity to sort of take stock of FSP and the immense value and potential that it offers and has been realized in California to date, and then sort of also look ahead to some of the upcoming changes I think that Emily mentioned through not only the Behavioral Health Services Act, but through other behavioral health reforms and initiatives that are taking place in California, because as I'll share, some of those have key intersections and are really relevant for thinking about the potential and the possibilities for full service partnerships moving forward. So just to sort of level set on the agenda quickly, I think what we want to do is just provide a recap, a quick baseline level set on behavioral health transformation. Today is, I don't think, intended to be a deep dive into all things related to behavioral health transformation, but just want to sort of frame up the key goals and then home in specifically on full service partnerships. Talk a little bit about sort of where we're coming from. I know the rest of the panel has deep expertise and experience with that, and so I'll probably be, echoing a lot of the commentary that you'll hear from this panel about current state of full service partnership. I think where I really want to focus on is, where are we going? Where can we go? What does full service partnership look like moving forward under behavioral health transformation? How does it intersect with other behavioral health reforms that are unfolding? And what are the key opportunities for the Mental Health Services, or soon the Behavioral Health Services Oversight and Accountability Commission, to really sort of dig in deep and really sort of add value and help the entire behavioral health field with shaping, thinking about, and optimizing and improving full service partnership? And then I'll close just by touching on key next steps with behavioral health transformation. So I think many of you could probably recite this in your sleep, but the behavioral health transformation in effect is the passage of AB 531 and Senate Bill 326 as approved by California voters on the statewide ballot measure that was voted on March 5th. There are two main components. So what those two bills did is they evolved the Mental Health Services Act to the Behavioral Health Services Act, the most major update and transformation of the MHSA since its enactment about 20 years ago. It also crucially provides about $4.4 billion in more funding for brick and mortar behavioral health facility expansion, similar in concept to the Behavioral Health Continuum Infrastructure Program or the BCHIP program that today has been monumental and instrumental in expanding access to behavioral health services in our communities. Some of the key themes or the high-level aims of the behavioral health transformation really are to establish key priority populations, to allocate and harness these resources to meet the needs of populations with the most significant inequities living with behavioral health conditions, improve accountability and transparency so that collectively, as Californians, we have more information and more sort of outcome benchmarks that we're aiming for the Behavioral Health Services Act funding to achieve. And of course, expanding capacity of facilities through the unprecedented bond. So I think, you know, where are we coming from? What is the landscape today and historically? I think, again, what Emily shared and what this panel shared will be much more illustrative about sort of this question than anything I can share. But, you know, just from my perspective, having worked at the federal level and having worked in a number of other states on advancing behavioral health system transformations, California is truly innovative and a leader, and truly lucky to have the MHSA. And within the MHSA, just my personal perspective, the FSP program is sort of the main engine for really addressing the needs and sort of marshaling system resources and philosophies and shared commitments to meeting individuals with the greatest needs. I think we know FSPs have demonstrated improved outcomes in Californians' lives. The evaluation that the commission submitted to the legislature found really key findings on impacts in housing stability, recidivism, behavioral health service utilization in intensive settings, and I believe employment status too. And so we know FSP can work. We know FSP does work. We know there are really, really strong pockets across the state where FSP has really proven to be exactly what we envision it being. We also know that there is opportunities to improve FSP to reach its full potential. We know right now, as Emily shared, there's sort of lack of standards, lack of standardization across the state in terms of what FSPs offer. So we know in some counties they're offering evidence-based models. We know in some counties they're engaging closely with consumers. They're offering culturally competent and equity-anchored care. We know there are really bright spots across the state. We know that's not scaled up and standardized in every FSP program in every single county. We know data is not where it needs to be. We don't have great data on what FSPs offer in terms of programming and services, let alone outcomes and impact. We also know that there are FSP sort of enrollment, caps, and there are many people who would benefit from a high-quality FSP program who aren't able to enter into FSP because at the local level, there's not really great segues or pathways for people to step down or step out of FSP if, for example, their housing is tied to their FSP enrollment, or because there's not sort of a standardized continuum of care to transition out of. So these are just some of the opportunities that we know exist today for improving FSP statewide. And so I think, through that lens, we can begin to talk about, what are the possibilities for FSP moving forward? What does FSP look like in a future state where the behavioral health transformation is enacted and after July 1st, 2026 under the Behavioral Health Services Act? So the sort of core fundamental goals of the behavioral health transformation with respect to FSP is really to build upon what we know works today, build upon the success of proven FSP programs that the Commission has found has led to improved quality of life, improved status, improved outcomes for community members. We know, just as the sort of independent evaluators have found, there's an opportunity to really scale evidence-based service models in FSP. And so we'll talk about what that looks like under behavioral health transformation and what that looks like in alignment and concurrent with other behavioral health reforms taking place that are really centered around that opportunity to scale evidence-based service models. The behavioral health transformation is really focused on improving data of all kinds. We need more we need a better picture and a better visibility into sort of how MHSA funding fits within the broader rubric, the global environment of Medi-Cal funding, SAMHSA block grant funding, local realignment funding, MHSA funding. These aren't programs that exist in silos. These are funding streams and programs that counties leverage and knit together to create a local continuum of care. And so the 3-year integrated service plan, the annual behavioral health outcomes and accountability transparency report, all of these are really focused on how do counties operate and strategically design a global behavioral health system at the local level instead of operating, and thinking about it in terms of different programs. There's also a key focus on outcomes data. So there's going to be a sort of a long stakeholder intensive process for defining what outcomes metrics look like and then tracking how the entire system is making progress towards those outcomes. And then finally, there really is a goal in FSP and broadly to make sure that where insurance coverage will fit the bill, that is leveraged. Whether it's Medi-Cal, whether it's commercial, we don't want BHSA funding to be covering services that 90% of it could be funded with federal dollars. Because if you take services that could be billable, could be covered by commercial reimbursement, Medi-Cal reimbursement, and you don't bill for it, you have less resources overall than if you do bill for it. That increases the total pot of resources that can be used to expand access that we know is so desperately needed for behavioral health services. So just to drill in a little bit more specifically, under behavioral health transformation, there are a few key components that are evolving full service partnership. I think number one is really standardizing the evidence-based practices. So there's a core focus on what have counties done today? What does clinical research tell us? What's really standard and best practice in terms of evidence-based models that are proven to improve outcomes, reduce emergency department utilization, reduce incarceration, reduce touches with law enforcement, reduce hospitalizations, improve housing status, improve self-reported quality of life? What are those interventions that should be available to all Californians, not just whether you live in a specific county that has decided of their own accord to offer these evidence-based models? So these, assertive community treatment, a model of assertive community treatment that is designed to meet the needs of individuals with experience with the criminal justice system, the individual placement and support model of supported employment, and high fidelity wraparound. Those are the service models that were identified and are well established that are proven to be key interventions for the priority populations called out and prioritized under the Behavioral Health Services Act. We know that when providers deliver these evidence-based service models, there are service criteria, there are, caseload and staffing ratios, and we know just by virtue of population sizes of different counties and prevalence rates, there are some counties that would actually struggle to meet the fidelity models of these services simply due to low population. And so we'll have a process in place to engage counties on, what does it look like to deliver ACT when the population in your county that truly needs ACT, wouldn't support a full ACT team. So there'll be an exemption process that is designed in consultation with stakeholders. One other key component that the Behavioral Health Services Act does is that it expands the option and the availability for counties to also use the behavioral health services funds to meet the needs of individuals with substance use disorder who don't have co-occurring mental health disorder. And this would really be driven by that 3-year integrated plan that counties develop and submit to the commission and to the department based on local data sources. So under FSP, the statute specifies that FSP would include assertive field-based care for SUD treatment, including medications for addiction treatment. This is pretty innovative. This is pretty new. While ACT and high fidelity wraparounds and IPS are pretty common and pretty standard across the entire country, looking at what assertive field-based, SUD and MAT starts look like is really new territory. And we know that is what the provider community and the recovery community is calling out for, to provide low barrier treatment to individuals right now, because the overdose crisis continues to hit record-setting levels, and the current treatment approach of asking people to, be fully abstinent on day one and comply with all the rigorous requirements that, are in place today, it's just not working. It's just not reducing that overdose death curve. A final key component of FSP is really using community-defined evidence practices. We know that there are community practices, sort of culturally commensurate models of care that aren't defined in the clinical research literature, that have been working in counties, in communities in California to meet the diverse needs of Californians. And so that is explicitly carved in as a core component of FSP. Just to round out some of these other changes, I think what Emily shared, and I'm sure what some of the other panelists will touch on, is that there's no sort of defined continuum within FSP. There's no defined levels of care within FSP. And so what the Behavioral Health Services Act does is it directs the department, in consultation with the commission, with counties, with providers and stakeholders, to really define a continuum of care within FSP, so that individuals are able to, receive the right intensity of services based on their needs, and are able to flow and journey through the continuum of care just like they would in any other behavioral health or medical care setting. FSP also includes other behavioral health services, ongoing engagement, and then of course there are modifications to the amounts of local assistance allocated to FSP specifically. Just to sort of contextualize these changes with the broader array of behavioral health reforms that, as Emily shared, counties are tracking, grappling with, putting these pieces into place. The core focus on lifting up and standardizing and scaling evidence-based service models that we know fundamentally work for people is not limited to BHT, not limited to FSP. You see this strategic alignment in other massive initiatives that are ongoing, including the BH Connect demonstration. The department submitted a Section 1115 waiver to CMS last October. We're seeking approval by the end of this year to do a number of transformations that would expand the continuum of outpatient behavioral health care across the state of California, including through a number of evidence-based service models, including through ACT, including through Forensic ACT, including through individual placement and supported employment, including through the coordinated specialty care model for early psychosis. These are also called out explicitly in behavioral health transformation. What this means is that by establishing coverage for these services, counties can opt in, decide to cover those services, and have the majority of those services reimbursed by federal funding. And that way you can really leverage and scale up the total pool of resources available locally for behavioral health care. We know, doing, clinical practice transformation and training providers and delivering care consistent with fidelity models doesn't happen overnight. You can't snap your fingers and make it happen. BH Connect and behavioral health transformation are sort of strategically interwoven to make sure there are centers of excellence that would be available for these evidence-based service models to provide free training and free fidelity monitoring to counties and to providers. And together, BH Connect would leverage a very small amount of the funding set aside in behavioral health transformation dedicated to workforce investments. It will turn around, use those local dollars to significantly leverage federal dollars to provide $2.4 billion in investments for behavioral health workforce expansion, hiring, recruitment, training, so that our workforce can be diverse, look like the communities in California that we're serving, receive the training we need for these services, and that's a key resource need that we know is desperately needed. So just to sort of wrap this up, I think, I was asked to share what some key opportunities could be for the commission to engage and sort of, dig in deeply into, the direction that FSP is moving and the possibilities that it includes as the Behavioral Health Services Act is implemented. And so, of course, there are a number of activities and opportunities that are prescribed and, established in the statute, where the OAC has a direct role. I'm not going to delineate all of those today, but I think specific for FSP, a couple things come to mind for me. One is really helping to map out and design what does FSP look like within a continuum of care, within certain levels of care, within standards. I think this is something that the third sector report, called out as a local need. And so you guys are so close to the field and so close to this work. I think the OAC will have a key role in really sort of shaping what that process looks like to map that out. Obviously, there's a wealth of new standardized data reporting that will be available to really drive system transformation. So this is the County Integrated Plan for Behavioral Health Services and Outcomes, the annual Behavioral Health Oversight, Accountability, and Transparency Report, and new performance and outcome measurement data. I think the OAC will be really instrumental in reviewing, evaluating, analyzing these data as they come in to really be sort of that laboratory that says, these are the key policy issues surfacing. This is what the governor's office, the legislature, the state departments, county behavioral health departments, consumers, providers need to be thinking about. These are sort of the major trends that are emerging from the new data that we have available. I think providing lightning fast TA and just real-time TA to support learning and diffusion within FSP and more broadly is also a key opportunity for the commission. I think, having that, that finger on the pulse of, this is what this cohort of counties has, begun to develop. This is an emerging best practice. This is what high quality FSP programming looks like. Then providing that TA, providing that training in a way that, optimizes counties' bandwidth, because we know that that has its own limits. I think that's really sort of a key opportunity that, frankly speaking, the entire field needs and would be looking to the commission to play that role. And then, of course, there's the $20 million annual in innovation funding that would be sort of at the disposal for the commission, and I think FSP is a key opportunity to drive that. So, just to wrap this up in terms of next steps, again, there are specific areas where OAC has a prescribed role in statute for consultation and advisement, and building out the FSP levels of care is one of those. There are more opportunities to engage for all members who are, and Californians who are joining today. There's information on our website and in the links that I'm sharing. And this is just at a high level what the timeline looks like for behavioral health transformation implementation. We've been holding public listening sessions to inform, and we'll continue to hold them, to inform the design of the bond funding opportunity for behavioral health facility expansion, for all the policy development under behavioral health transformation. This summer, more information about how to apply for that bond funding will be made available. And then beginning early next year, there will be sort of a phased rollout of draft policy guidance for that 3-year integrated service plan, because that's really going to guide how, the BHSA strategies are developed locally. So there will be a ton of material coming out that we will be seeking input and stakeholder feedback on to make sure that it's as good as it can be. And then, of course, in the summer of 2026, a lot of this begins to take shape. So I know that was a lot of information. We do have dedicated mailboxes and landing pages. So hope to hear from everyone who's interested.
Thank you so much, Tyler. Yes, please, Commissioner Brown.
Yeah, thank you, Tyler. Just a quick question. On the laundry list of acronyms representing programming on the strategic alliances slide, I didn't see medication-assisted treatment anywhere. Is that a subcomponent of one of these other ones, or?
It absolutely is. Thank you for asking. I actually had a whole slide developed around SUD, medications-assisted treatment, and I know our time is limited up here, so last night I made the call to cut the slide. But absolutely, the department and the administration is taking, using every single lever we have available to increase access to medications for addiction treatment. Happy to provide more information. We're taking steps through facility licensure requirements, facility certification requirements, reimbursement policies and requirements in the drug Medi-Cal organized delivery system. As deputy director, I commissioned ASAM to develop clinical guidance on basically, what does it look like to have low barrier treatment so providers can revise policies and procedures to make access to MAT more available. We're hosting harm reduction summits across the state so that we're inviting, folks from every sector, from public health, law enforcement, the provider community, the recovery community, to learn more about what does it look like to do harm reduction? What does it look like to make our treatment system more patient-centered and reflective of how we manage chronic diseases in other parts of our body? Because with substance use disorder, we just restrict access way too much. And so that is a key focus.
Thank you, Tyler. So, commissioners, I apologize. In the beginning, I should have stated this. We're going to go through the panels and then ask questions. However, if there is a pressing question during one of the presentations, of course, I invite you to ask it. I would ask that you, though, do hold your questions. Jot those down so that we can get back to it and ask the panel as a whole. But I do want to invite Commissioner Bunch to ask her question, please.
Only because I said, why did Bill get to go?
We have to be fair here.
Tyler, I was just curious, is there any timeline around when the counties would start getting training on the EBPs?
Great question. So we are, I think, we are looking to put out a request for information shortly, if it hasn't gone out yet, around the Centers of Excellence, call it platform. And the Centers of Excellence are really designed to be organizations that have experience with doing this today, providing training on EBPs that are called out in the Behavioral Health Services Act and in BH Connect. The Department of Healthcare Services would be funding those centers of excellence. And that would be, we'd really want to make sure the centers of excellence are offering training not only in a way that reflects the standard model of care that is, sort of well established and exists today, but also reflects the local experience of counties that have done this today and have sort of developed tailored approaches to make sure diverse communities are successfully engaged and welcomed into care. So we're really making making sure that translation and that modification is part of the philosophy and the strategy for how the COEs offer training. I think, this shortly, and I will follow up on the specific timeline, but we do hope to put out an RFI so we can hear from all Californians and stakeholders, like, what is your experience with this today? What does it look like? What are these organizations that are known to us that have this type of credibility and expertise? I mean, just one that comes to example, right? UC Davis with the EpiCal program for first episode psychosis. We know that is a very promising example of what a Centers of Excellence would be for the evidence-based practice of coordinated specialty care for first episode psychosis. Just wanted to share that one as an example. But we can follow up and share a timeline as you requested.
Thank you. We will go ahead and move on.
Thank you. Good morning. Thank you for inviting me to come and talk to you this morning. My name is Richard Johnson. I'm the Chief Executive of the Healthy Brains Global Initiative, HBGI. Do we have the slides coming? They're behind the wall. I'm going to start whilst we wait for the slides. We were contracted by yourselves last year to have a look at full service partnerships with a, with a specific focus on the way that they are contracted and the way that they are performance managed, with a view to asking whether there is scope to improve the outcomes that people achieve through their participation on the program. So we spent around 6 months, starting with desk-based research, a number of virtual conversations with people at state level, with the department, with colleagues in the OAC, with people in the county behavioural health teams. And we spent around 6 weeks here on the ground, on and off, in 6 different counties doing a deep dive, small, medium and large size counties, going and talking to service providers and looking at the services for ourselves. And of course, speaking to people accessing those services. And it was the people on the programs themselves and their families and their peers and the very humbling and moving conversations that I personally had with them that really taught me the most about these programs and the scope that there is for quite significant improvement. The report is, I believe you have copies this morning. It is available online on our website and I think on the OAC's website too. Just briefly on my own background, I studied psychology many, many years ago at Oxford University. I had an early career in international education, but for the last 25 years, I've been working on outcome-based contracting, performance-based contracting. So how you use contracting as a tool to drive the performance of your services, with a particular focus on vulnerable communities. I set up and I ran a series of for-profit service providers delivering under contract to governments in the UK, France, Germany, and Australia. I was a senior consultant for the World Bank for 10 years, delivering across a range of different countries, mainly Ethiopia and Afghanistan. I was a senior advisor at the Global Fund, that's TB, HIV, and malaria, again asking how do you use contracting to increase the impact of services targeting those diseases. And I've been involved in chairing things called impact bonds. I don't know if you know them. They're a type of outcomes contract that uses social investment. And I've worked across 10 of those around care for carers, refugee integration, school exclusion, homelessness, and I currently have a youth employment program running in the West Bank in Palestine. We are joined at HBGI by our Chief Medical Officer, Dr. John Sherin, who I think many of you already know. He is a rather remarkable street psychiatrist with an incredible track record of delivery in the behavioral health space, including 5 years of leading behavioral health services as director in Los Angeles. And I think where John and I are particularly well aligned is in our belief that the quality, the success of a program depends on your ability to build it around the individual who is receiving that service, who is accessing that service, and your ability to ensure that that individual's progress towards outcomes are addressing the needs that are meaningful and relevant to them. So some observations that you would find in our report, and then I'll describe a little bit of the technical assistance that we're currently undertaking here, and then I'll pass over to Dr. Sherin, who will do a little bit of blue sky thinking for us and just push our thinking forward to what the system might look like. There is no doubt that FSPs save lives. These are remarkable programs in global terms. I have never come across any investment like this in services targeting a group with such complex needs. They save lives. They are delivered by highly committed and very professional people with close support in general from the community health teams, behavioral health teams. There is wide variety in these FSPs across the state, in the quality of the service, and in the money that they spend on each individual. And we think there are opportunities for significant improvement. You spend, it varies, but give or take, let's say $1.5 billion per annum on FSPs. So in coming to review these programs, obviously my first question was, could you please tell me who is the best and who is the worst at this? Because I want to go and see them in order to be able to learn. And nobody could tell me. Nobody at the state level, nobody in counties. Indeed, I spoke to service providers. I spoke to one service provider who had 25 different contracts across a number of counties, and they couldn't tell me which of their contracts was performing well and which was performing badly. If we have such poor lack of transparency, how do we have accountability within the service? And indeed, how do we know that we aren't failing some of the individuals on those services for whom we have clearly a duty of care? They are running generally well under capacity. So across the piece, they run at about 70% capacity. This is not true of all service providers and all contracts, but generally across the piece. And I'm focusing here on the adult FSPs. There's a number of reasons potentially for this under-delivery, this under-resourcing, and it is generally a question of resources. So I'm told we're running at 70% because we cannot recruit the staff. Or having recruited the staff, we can't retain them. We have a very high staff turnover. Again, this is not true of all service providers, but many of them will tell this story. These staff go into the profession knowing what they're going to earn. They know what the service is or should be, but the way it is currently configured is taking the heart of the service away from them. They are not being allowed to do the job that they went into the service to deliver. And this is largely because, whereas the program might once have been about whatever it takes, it's now actually about whatever we can bill. When you talk to these services about what success looks like, they're most likely to talk to you about two things. And one of those is what they call productivity. Now, productivity for me means a high level of meaningful activity. Productivity within these services means the level of billing that is going on. And they drive targets of productivity right down to the front line, to the case managers who have a weekly target that they have to achieve. Success otherwise, of course, is described in terms of a reduction in incarceration, reduction in hospitalization, and a reduction in hopelessness. And these are described as the outcomes of the service. Now, I presume you are aware of the way of describing services in terms of a results chain. So we have inputs, outputs, outcomes, and impact. So by way of an example, if this was an employment program helping people find jobs, the input might be a training program. The output would be them qualifying from that program, passing from it. The outcome would be people securing a job and sustaining it. And the impact would be a reduction in unemployment and an increase in economic prosperity. When we talk about outcomes of reduction in incarceration, hospitalization, and homelessness, we're talking about impact. We're not talking about the outcomes achieved by the individuals on the program. When we talk about moving towards a more standardized, evidence-based approach, I beg you to be cautious and careful, because that's all about inputs. And that's about prescribing the inputs. Again, it's missing this bit in the middle, which is all about the individual's progression through the program and their achievement of outcomes that are meaningful to them. When you start on a child FSP, you are generally informed, you and your family, that the program is time-bound. So you're going to be on the program for 10 or 12 months. When you start on an adult FSP, you are not told this. Indeed, the expectation in many places is that you will be on the FSP forever. We will wrap our arms around you and we will care for you forever. One of the consequences of this, of course, is that it significantly reduces your utilization of this resource because it's full of people who are stuck there. It's also generally not in the best interests of the individuals. It might be keeping them safe, but we are keeping them in a position of need. We are focusing on their deficits, not their strengths, their potential, and their power to progress. If, in Dr. Sherin's words, this is all about connecting people with community, and he defines community in terms of people, place, and purpose, the FSPs are doing pretty well on people, at least in terms of engaging them in groups and connecting them potentially with peers. On place, of course, there are constraints out there in terms of the housing stock, but generally they are moving people into some sort of accommodation, which is sometimes safe and of quality. But we're not doing at all well on purpose. we've completely lost sight of enabling people to achieve something that is meaningful for them to do. Some of you were on the visit to the Secure Hospital in Napa in February, I think it was. I joined you on that day, what an extraordinary day. And the highlight for me was the conversation with the 20, 30 individuals who were resident in that facility at the end of the day. And I can't remember who it was, but one of you asked, what are your plans for when you leave here? What are your objectives? What's your purpose? And they came alive. It was electric. They each had a clear plan of what they were going to do, to reconnect with their family, to write a book, to do all sorts of different things. I asked the same question of people on the FSPs in a number of different contracts, a number of different places. And they had no plan. They had no goal at all, other than to keep coming to the FSP. And it was tragic to hear. There have been attempts at incentivizing outcomes on the program, but they have generally failed. I'm afraid those incentive schemes were badly designed. They gave an opportunity of an additional 2 to 5% of money to the service provider linked to achievement, potentially of outcomes, but also to a whole bunch of process-oriented key deliverables. And they were unachievable, and Los Angeles informed us that they have not paid out $1 in incentive payments on that scheme. If you deliver more meaningful services for more people, enabling more people to achieve outcomes that are relevant to them, the billing will look after itself. But right now, that tail is wagging the dog. Very quickly then, before I pass on to Dr. Sharon, we've commenced doing some technical assistance. So we are being funded by yourselves at the OAC and also by Nevada County and Sacramento to go in and support 6 of their FSP contracts to strengthen their performance management. So by this we mean that instead of simply reporting on their impact on an annual basis in terms of incarceration, hospitalization, and homelessness, we want to see on a monthly basis what is going on within those services. So we're right now engaging with the service providers and the counties to develop what we call a performance pack. And that pack will set out each month what activities have been delivered, how many people have attended programs, what programs they attended, who has got objectives, who has got a plan in place, are they progressing against those objectives? And each month we will sit down and review that activity and ask, what are we going to do differently next month in order to improve this performance? How powerful it would be if you had that across the state. If you could see every month how every single service provider was performing, if you could compare them, if you had the transparency and accountability that it would bring. It also enables you there to share best practice, to find out who's doing a great job and to promulgate that learning. We're also hoping, and we're in conversation right now with colleagues in Orange County, to look at piloting some outcomes-based contracts there, where we will look to attach significant incentive payments to the achievement of purpose-driven outcomes for some of the individuals on FSPs. I'm going to pass to Dr. Sharon now, who, as I say, is just going to lift us up out of the weeds a little bit and propel us to look forward. I'll switch.
Thanks, Richard. Quick correction, 6 years in LA County. And it's great to be here. I had a brief period of time with you up in Napa. I'm used to being on the other side of this thing with innovation projects. Had about 10 of them during those 6 years that went through. I also want to recognize Hector Ramirez, who made some comments. I don't know, Hector, if you're still on, but it's good to see you and your relentless activism and advocacy. It's truly impressive, and I share your spirit in trying to move the systems and in terms of having frustrations with the system. And my work now, which is largely international, continues to focus on improving stuff in California, where I live and where I have a lot of interest in trying to help. And I would say during Mental Health Month that it's not just celebrating Mental Health Month, but it's about leveraging Mental Health Month and all that we've been through with COVID and a variety of other global stressors global stressors, to shine the light and to push reform with courage. Because we need to. With that in mind, CalAIM and Prop 1, which are not going to be easy to implement and are, I think, creating confusion in many ways, have to be implemented in the most thoughtful way, and in a way that I like to always say empowers the trenches. Empowers the trenches, meaning the frontline providers and the clients, which is where the work happens, where recovery can occur. And early on in my career in LA County, I became very focused on full service partnerships and some of the things that were not happening that clearly had to happen to help lift up individual clients and families. And it took me a long time to find out why. And staff in general, when there's a new director in town, aren't always divulging information, but it had to do with the fact that certain things were not billable. And as Richard's saying, billability cannot drive our system. Outcomes of human beings must drive our system. With a generous gift from the Ballmer Foundation, I managed to bring in Third Sector, who worked diligently with me and my teams to create what we called at the time FSP 2.0. So for me, this is a 3.0 conversation. And FSP, I think, as Tyler points out, really is the meat and potatoes of community mental health. So if we focus on it, recognizing that it has a position in a continuum of care, it will help lift up the whole system because it's the entree in a recovery-oriented system. So I come to you to talk a little bit about some blue sky thinking. I'm probably a broken record for many people who have heard me speak before, but it's because it's what I believe, and it's what I would want if I were in my old shoes as the Director of Mental Health for LA County. And one of the first things that's problematic that I think we've heard across the board is data collection, analysis of data. The systems are so disparate and fragmented. That's a problem. It's a problem politically, it's a problem financially, it's a problem in terms of tracking what's going on, and we have to do something about it. We can't just continue to have individual counties collecting data, having data not be shareable between providers, counties, with the state. Quite honestly, I don't think the state has clearly identified how data is going to be centralized, who's responsible for it. And that's a big problem, and I think is an area for significant investment. One of the entities that I worked with a lot, CalMesa, is in the process of developing a shared electronic medical record, collecting information, and doing billing, I've learned very recently, which is a big deal. The first 6 months I was in LA County, I spent it going to our clinics. I didn't get to all of them, it's a big county, but I got to a lot of them. And I talked to frontline providers. And I asked some of the supervisors and managers to step out so I could find out what's really going on the ground level. And to a person, the front line said, we spend most of our time doing paperwork, taking care of medical charts and billing, which is exhausting. And not only does it take time, it also takes the energy, the motivation. It's demoralizing as a frontline provider to spend so much time dealing with the administrative as opposed to the clinical and the human service oriented. So can we figure out as a state how to develop a hub, a repository that will collect information that can tell us a lot of things that are going on and take the burden off of the front lines in terms of billing? I think it's happening, and I think it really, really needs to grow. We talk about outcomes all the time. One of the things about outcomes that I think is critical, fundamental, is the outcome for the individual. What does that individual want? Top-down solutions never work. I often say that the grassroots must inform and drive the grass tops, and I would say that about individual people getting care. So we need to provide a framework and a system so that as a state, and of course I like the people, place, and purpose framework, will allow providers to understand what that means for each individual getting care in an FSP program and make that the benchmark. That is performance. And it highlights the voice of our consumers, which at the end of the day is the most important data piece that has to be incorporated. The last thing I'll say is that if we're going to really become accountable to outcomes, and I say this to this commission, we have to look at what's incentivizing the work. And if we shift to pay over time, and I know that this is not a simple thing at the state level, at the Fed level, to pay for outcomes, not paying for services that qualify, we will reform the system from the ground up. This requires cultural transformation. We have to move from billability to accountability for achieving outcomes, pay for those outcomes. That to me is the ultimate solution for driving the reform, for getting people in the trenches to do what's important, not what they can get paid for. And I would love to see that happen, whether it's in pilots, demonstration projects, whether it's something that we as a state can look to as a next version waiver. But we have to empower those trenches. And if people are just going about their business doing the same type of bureaucratic process that we have been for a long time, we'll never be able to get where we need to go. At the administrative back end of the different parts of funding, which are fragmented and difficult to configure, that's on the government. We need to empower our front lines to do the work. I thank you very much for inviting me back in. It's really nice to be here.
Thank you very much. We are going to also ask our presenter online if they are.
I'm here.
Thank you. I think we can hear you just fine.
Wonderful. Are you prepared for me to start?
Yes, please.
Thank you so much. I want to thank the commission for the flexibility to permit me to present virtually today, given other commitments at the local level. It's really an honor to be here to share the work of Fresno County. And I appreciate the support also for the advancement of slides on my behalf. Next slide, please. This slide shows something that we present at all of our formal meetings and presentations. I won't read it to you, but I want to emphasize to you the reason why the word quality shows up in our mission, as well as the goals here emphasizing quality. The reason for this is that this is a primary driver for the Department of Behavioral Health here in Fresno, and embedded within our 11 guiding principles, not shown here, is a commitment to continuous quality improvement. Next slide, please. So as many others have shared, FSPs are often the highest level of outpatient care in communities. Here in Fresno, we've partaken in some fidelity assessments to determine where our full service partners are in our goal of getting them to be assertive community treatment models to fidelity. And we have some work to do on that. Some of our providers are closer than others, but until we achieve our high fidelity standards for ACT, the traditional FSP is our highest level of outpatient services. They do provide a high frequency of service encounters each week. Some of those encounters are claimable. I heard lots of emphasis on billing today, and other activities and services are not Medi-Cal claimable. They do provide availability 24 hours a day, 7 days a week from a team member known to the person served, who's part of their multidisciplinary treatment team. And then of course, our full service partnerships meet folks where they're at, and we do mean that literally and figuratively. This requires a mobile workforce providing services in the field. For some of our programs, that means driving around our community, 6,000 square miles here in Fresno County, looking to find the person that we're looking to engage. Next slide, please. So you heard from our colleagues at Third Sector, and Dr. Sharon referenced their work with Third Sector as well. We are in that mix. Fresno County recognized the opportunity presented by the commission some time ago to learn and strengthen FSP care, and we jumped right on that opportunity. We thought this was a fantastic learning opportunity. We had recognized some opportunities to think about how we deliver FSP care differently, but we didn't have the data to necessarily drive the direction that we wanted to go. So the Third Sector project created a wonderful platform for us to engage with the people we serve and with our contracted full service partnership providers. In Fresno County, all of our full service partnership programs are operated by contracted partner agencies, not county staff. In that work with Third Sector, a few themes emerged for us. We had a clear need to do some standardization. We had an opportunity to think differently about how we monitor the care provided as well as the contracts. The theme of data is coming up in all of our panelists' presentations today, and certainly we were uncovering lots of opportunities related to data. As others have mentioned, step downs to lower levels of care was certainly a great need. And then anchoring through all of the full service partnership conversations was this great need for us to have housing addressed. And the way our housing services in our full service partnerships work currently is that the full service partnership budget has some funding that they can utilize in the context of the full service partnership program to support folks in housing. But the challenges with housing remain in our community, and I don't think Fresno's alone in this. There's an insufficient inventory of housing units. There's not a robust enough inventory of residential care programs and permanent supportive housing. Housing costs are rising rapidly in our community, and I'm sure others as well. And then, as I mentioned, the housing dollars were tied to the full service partnership contract. And so we know with the Behavioral Health Services Act transformation, we'll have an opportunity that we have long desired to disentangle those housing dollars from the level of care inherent in a full service partnership. Next slide, please. I'll take a deeper dive on a couple of those themes that we identified. The first is the standardization and step downs. We realized in this work early on in evaluation and analysis that standardization was necessary. We had different practices, for example, of how a person could access an adult FSP compared to a child or adolescent FSP. But as we focused on standardization, we also learned that we needed to have flexibility for the very important population-specific needs to be addressed. So for example, in Fresno, we have created for a number of years, full service partnership programs for designated populations of focus. For example, we have a longstanding full service partnership program that's dedicated to our rural communities. These individuals often have some of the greatest barriers to accessing services within their community. Many of them are monolingual, and so we're able to meet their cultural needs as well as their geographic needs. We also developed and submitted out to the community a full service partnership RFP quite a number of years ago for culture-based full service partnership services. And through that procurement, Southeast Asian community was identified as a population where services in the context of culture was added value. And so we lifted up that program a number of years ago. We also have full service partnerships focusing on children, transition aged youth, persons with justice involvement, and importantly, persons with co-occurring severe mental health conditions and severe substance use disorder service needs. So while we recognized we needed to have some standardization, we don't want to lose the flexibility for those community-defined evidence practices. And I was excited to see and hear from our colleagues at DHCS the commitment to those CDEPs as well. We believe that these population-specific FSPs increase access and promote retention in care, and it helps persons connect with context of culture, age, and shared life experiences. We think this really helps drive that purpose and meaning that Dr. Sharon was referencing a few moments ago. And in the context of data, which I'll cover momentarily, we really want to make sure that as we standardize measurement and the metrics that we select, we want to be sensitive to those nuances of the various demographics. Next slide, please. So the other thing that we learned in our efforts of standardizing was the value of having those options for step downs. In some of our full service partnership partner programs, we also had what we call a continuum of care contract. So for example, the rural FSP that I mentioned previously, quite a number of years ago, we intentionally did that procurement where we would have a full service partnership contract. And then within that contract, a separate scope of work and a separate budget, separate cost centers to track it differently for lower intensity services, so that within the context of the provider that's operating in those rural communities, known to the person served and their family and their natural support system, they could step down when they're ready to graduate out of that full service partnership level of care without having to build a brand new relationship with a different organization, different people that they've never met before. And we had a couple of those types of programs with a continuum of care. Since that time, through our evaluation, we also recognized that the contract providers that we had FSPs without multiple levels of care, they were impacted significantly with challenges in transitioning care. We know through evidence and research that transitions in care are one of the greatest vulnerabilities for the people that we serve. And so we saw a great impact on length of stay. FSPs were hesitant to graduate someone out of their program because they were very concerned about the potential for the person to regress in their recovery or to fall through the cracks of a very large, complex system of care. So based on that learning, we've expanded our strategy of continuums of care in our FSP contracted programs. As I mentioned, those lower levels of care have separate budget and separate scope of work. Currently, we call those levels of care intensive case management, and then a lower level of care of outpatient. And we collect the data separately, as I mentioned. In a post-payment reform environment, those lower levels of care are fee-for-service contracts, and it does afford those contracted partners to keep people in services, maximize their revenue, while preserving relationships as people get more well. And again, graduation is something that we want to emphasize from hello. So we want people to see when we welcome them into our system that recovery happens, and we fully expect that they'll transition in their recovery journey. Next slide, please. As I mentioned previously, we determined through the evaluation that we had some excellent opportunities to improve how we monitor the care provided in our contracts, as well as the contracts themselves. One of the things that was a vulnerability for us that we identified was that our contractors were a little bit operating in a vacuum. And sometimes because they are not integrated into our continuums of care outside of their own program, sometimes they didn't know how to affect action in other organizations where the person's needs could also be met, such as within an inpatient hospital, if there was a need for that, maybe within the physical health space. And so one of the things that we were able to do is to increase the number of staff and the focus of staff in a classification that we call utilization review specialist. And we specifically embedded these clinical practitioners who focus their time on utilization. We embedded them within our contracts teams. We have excellent administrative personnel in our department, and I'm so grateful to work alongside them. One of the things that we wanted to honor is that they don't have clinical expertise. And so there was sometimes a need for someone with clinical expertise and background to come in and be the conduit for our full service partnership providers and our contracts team to help navigate our system. Those team members also are able to help our FSPs ensure that people are in the right level of care, that we're facilitating those conversations toward graduation and step downs in care. And again, just overall communication and collaboration improved. Next slide. With that said, about collaboration improving, it was not without a lot of difficult conversations. And as we, again, are in a post-payment reform environment, we continue to have lots of. Can you hear me?
Yes, we can.
My apologies, I hit the space bar. We continue to have meaningful and challenging conversations with all of our contracted providers. What we found in the third sector work was that as we started to talk about monitoring our care and monitoring our contracts differently, there was a lot of conversation around trust. There was a lot of thoughts shared with us about the level of autonomy that our service providers have or may perceive that they don't have. And I think it was actually strengthening our relationships with them. Certainly, we have identified the need to increase communication. I would say that no matter what survey we administer, no matter what meetings we hold, I continue to receive consistent feedback that communication remains an opportunity. And so we're committed to continue to strengthen that as well. The last thing I'll say on the monitoring of the level of care in the contracts is that our department has been preparing for a couple of years for a very significant reorganization of the management of our work. And this has been influenced by many different data points, including input from people we serve, our provider network, our own department staff, our communities, as well as our formal assessments and evaluations, such as the third sector work. We have made a lot of different changes that we're in the process of executing, but for the purposes of this discussion, I'll share with you, we're increasing a focus of our resources on quality management. We're going to standardize our contracts governance and focus resources toward that. And we're integrating our clinical care business lines around special populations and integrating mental health and substance use disorders. Next slide, please. Transitioning our focus of discussion to data, again, I know that's an important theme that we're reviewing today. Our full service partnership providers and our team members here in our department have identified that the data system known as DCR, the data collection and reporting system, did pose many challenges for us. One of the challenges is that we really do want to have actionable data that we can utilize for quality improvement and process improvement. And in that particular data structure, it's not easily accessible. Another thing is that there's a lag in the data. And so we want to have more real-time data accessible to us so that we can identify opportunities to improve more rapidly. And then having access to that raw data to run analysis is really important. When we receive generated reports downstream, it does limit our ability. I also want to acknowledge that not all counties have the same resources at the local level to do that deep data analysis. We're a large county, but we're in an area of the state that has a lot of workforce challenges. I know that's not unique across the state, but our workforce challenges date way back before the pandemic here in the Central Valley. We do have some really brilliant capable team members here in our community. But we have also found great success leveraging our Joint Powers Authority. I know Dr. Sharon mentioned CalMesa, and that's a really great opportunity to bring in very specific data expertise and shared resources. And I'm proud to say that Fresno County is one of the counties that opted in the semi-statewide EHR through CalMesa. And we see great opportunities to work together to streamline data collection in that way. And then I also heard one of our colleagues, I believe it was our colleague from Third Sector, who talked about learning collaboratives. And we do see this as a great strategy to help drive improvements across the state. Our county is grateful to have been selected in the Medi-Cal Behavioral Health Learning Collaborative through IHI. We're in partnership with our two of our 3 managed care plans in that learning collaborative. So we see great value. There's always a flip side, right? Every strength has an Achilles heel, and those learning collaboratives do take time, and it does consume resources. So there's strengths and opportunities with that. Next slide. Again, on the data collection, thinking about the methodology and how we collect the data and how we can make it actionable. One of the things that we recognize through our full service partnership evaluation project is that while there is value in the data, there are some indicators that are very meaningful. There's not necessarily within that information that directly improves the clinical outcomes for a particular person served. And so we really want to think about how we can make the data meaningful and actionable at the clinical level. As Dr. Sharon said, in the trenches, the case managers, the psychiatrists, the clinicians, the peer support professionals who are doing the work day in and day out, that the data needs to be real-time and actionable for them as well. One of our providers was quoted in our third sector work saying that they use the DCR because they have to, even though they may not feel that it's the best tool to help them deliver their care and evaluate their work. Next slide, please. So a few opportunities for the future. We do believe that it's important to have clinical significance and meaning with the person served. We have some great experience of having data-informed discussions with the people that we serve about their own strengths. And we know through the work that we've done at the local level that the people we serve can reflect on their own treatment progress and goals during data-informed care. This requires us to make sure that the data that we're talking about here is clinically actionable and embedded in part of the clinical workflow. One of the challenges that we have with data collection is that often results in forms. And these forms are often various add-ons to the clinical process and really detracts from the care conversations with the people that we serve. In spite of great progress on documentation reform, which we're really appreciative of, we see great value in the reforms to documentation that have already occurred. We do continue to hear practitioners citing regularly as their reasons for leaving the public sector behavioral health workforce, the burdens of administrative tasks and paperwork. Sadly, we do see folks taking those evidence-based practices with them. We've invested, hundreds of thousands of dollars in evidence-based practices such as dialectical behavioral therapy, early childhood mental health specialization, and numerous other practices. And many of our great clinicians have left our contracted programs as well as our department programs going into private sector and taking that wealth of knowledge and skill with them. And then, as I mentioned, leveraging technology across systems is really valuable. We're very hopeful about the value of the semi-statewide electronic health record and the interoperability that it affords, because we don't want to have clinicians checking a box on a form asking a person if they've been to jail. We want to be able to pull the information from the jail records and merge that in our electronic health system so that we can have the data accessible without having to ask a question or check a box on a form. Next slide. And again, streamlining data across programs and across levels of care to tell a recovery story over time by population and across programs, I think really adds value. Again, without having the administrative burden of the data collection at the clinical practitioner level. And I think we need as a system to account for clinical interventions that are claimable and non-claimable, because I think that it tells a different story than just looking at our claims data. I do believe that it's imperative as a full system of care across our state, certainly this is valuable to me at the local level, that we analyze our behavioral health outcomes, mindful of the full continuum of services that may be available to people in our communities before connection to a full service partnership and after their graduation from a full service partnership. And I think we need to include looking at what was available to them and utilized or not available and not utilized in commercial plans, as well as in the managed care plans of Medi-Cal. And then analysis of co-occurring mental health and substance use disorder services data is really important to promote opportunities to streamline and integrate care and ultimately improve outcomes to those we serve. Next slide. Starting to wrap things up for you all, thank you for indulging my comments this morning. I do believe very strongly that standardization works best when grounded in research. Clinical research, and then also looking through this lens of equity, whether it be geographic indicators, culture, language, population-specific needs. We really want to make sure that we approach standardization with an equity lens to address health disparities. I was really excited to hear the conversation around incentivizing quality of care. I think we also need to incentivize a well-trained workforce to stay within the public sector where we have such a great need. We want to ensure that we have appropriate monitoring while also keeping an eye towards sustainability for the future. I did mention earlier about having sufficient housing inventory, and I'll add here that we need to have an array of housing options that's adequate to meet the needs of people with numerous complex needs. So whether it's staying within their geographic area, for example, I mentioned our rural continuum of care. There are very minimal housing resources in Huron, for example, here in Fresno County, much less permanent supportive housing or residential care. So we really want to make sure that we're emphasizing the housing inventory. A colleague previously mentioned about the engagement activities that are necessary to help support persons to be engaged in behavioral health care, and we need to have a rate structure that's adequate to be able to do that important work, irrespective of whether it's Medi-Cal claimable. And then disentangling funding from housing for FSPs versus the housing itself. I do believe this is a wonderful opportunity ahead for us, because fundamentally, I do not believe that people should lose their housing because they get better. Next slide, please. Lastly, my very last slide, aside from perhaps a thank you slide, the analysis of all of this work is complex. We can't look in a vacuum just at a full service partnership program. We want to also be able to determine how the additional services that people participate in complement and advance their recovery. So for example, we have persons who participate in services at the Wellness Center. We have a variety of services that are rooted in culture as well, and we want to be able to understand all of it in total. I mentioned about effective outreach and engagement, very important for us, and then retaining that well-qualified workforce. And I'll round out my comments this morning with appreciation, and I can only represent Fresno County with my comment here, but I have great confidence that all counties and providers are as I say here, delivering meaningful services. That was evident in the third sector report, as well as our colleagues who presented on the work that Dr. Sharon and their team have been doing. The services are meaningful, and there's an unrelenting commitment and passion for the people that we serve. We stay committed to advance improvements across California, and we look forward to opportunities to continue to be included and engaged in the conversation of how we set standards and how we set measurement across California. Thank you so much for lifting up Fresno County today on behalf of all of those we serve and our wonderful team members who serve them. Thank you for this opportunity.
Thank you, Susan. Very informative. I want to encourage my colleagues to ask questions because I have a lot, but I don't want to take up all the time. So already Commissioner Chambers has asked to begin.
Thank you. I'm going to ask just some global questions for the group or just thoughts relative to procurement, billing, innovations, and incentives for the workforce. As I've been, I represent the client and family members, so I've been a part of some of the behavioral health transformation calls already. And I know what I hear is that with Prop 1 reform, it's really going to be utilizing and leveraging like existing dollars to draw down federal dollars with Medi-Cal. That could be incorrect, right? But Medi-Cal is definitely, billing is definitely like, I believe the future, it sounds like, of it and drawing those federal dollars down. So how does that align with a proposed potential like capacity build or pilot program that really would be focused on incentives, kind of like HCIs, like performance-based? How would that fit into a model that we're really moving towards with billing that's just based off what you can bill and not off the outcomes that you were talking about? I just want to kind of, or is there new legislation that needs to be made, or like, I know that Prop 1 hasn't been completely implemented, but I just wanted to know kind of like, what are the thoughts of like marrying those two concepts right now? I know, Tyler, you're here listening to this conversation. You guys have probably had conversations. How does that hypothetically look in the world of the future of behavioral health? That's one part, but I'll pause.
It's a terrific question. So I want to make sure folks feel comfortable that, you know, what behavioral health transformation does not do is require everything funded by BHSA funding be billed to Medi-Cal. Like, not a requirement at all. The goal that's in the statute is really that if there is a service that a county is delivering using BHSA funding, and that service could be billed to that person's health plan, whether it's commercial, whether it's Medi-Cal managed care, whether it's the county mental health plan, that the county should pursue that reimbursement. So it's definitely not a requirement, but I think, as you put it, it's sort of the future is to really leverage all funding sources so that MHSA is not the backbone holding up the world of mental health, but rather commercial plans that are in the Fortune 100 and have market capitalizations of $150 billion, like they should be paying their fair share too. So should the Medi-Cal managed care, so should the federal government for Medi-Cal. Then for paying for performance, I'm so glad Dr. Sheridan brought that up, because one of the initiatives, one of the many that Emily alluded to, is CalAIM behavioral health payment reform. And so everything under BHT is really intersecting with all of these other initiatives. And what CalAIM behavioral health payment reform does is, in my words, it takes us out of the Stone Age and moves us into the Bronze Age. It means that providers are now able to receive reimbursement on what's called a fee-for-service model. That's not important. What's important is that behavioral health payment reform provides all of the authority necessary for counties to develop value-based payment models. Full stop. That's the value, that's the promise, that's the potential of CalAIM behavioral health payment reform. We've seen one county, and I'm glad Dr. Sheridan from LA is here, because the LA DMC ODS plan has actually done this. And this actually weaves into comments from another commissioner, what LA has done for substance use disorder is already today, currently, under Cal-Am Behavioral Health Payment Reform, they're offering pay-for-performance incentives for how their substance use disorder network providers offer care, improve care, make care more patient-centered, remove barriers to care, offer medications for addiction treatment. So the providers in the LA DMC ODS that do this today can earn two types of financial incentives. One is based on the capabilities that they have, the types of care that they're offering, and one is actually based on incentives, like the type of care they're delivering and the outcomes for patients. So LA is way ahead of the curve. That's where we want all counties to be eventually. And what Cal-Am Behavioral Health Payment Reform does is it enables every single county to do exactly that, so that FSP really is, shaping, and all Medi-Cal services could potentially be shaping the type of care we want to see, rather than just paying for volume of service utilization.
But how does that work?
Oh, go ahead. No, go ahead.
How does that work when the programs are going to be required to use EBPs? How do you pay for service as well as using a very specific form of treatment that doesn't appear to be outcome-based?
Yeah, so great question. So I think there's sort of like, you can deliver one of these service models and also be paid not just for delivering the service, but sort of based on outcomes. So you can have both, and it's sophisticated. And in the behavioral health space in general, like regardless of what state you're in, regardless of what payer you're in, behavioral health is not as advanced as types of medical care where this is pretty commonplace today, like capitation at-risk based payments for covered lives or paying for certain outcome metrics. This is new for California, so we're going to figure this out together. But it's totally possible to deliver, for example, one of the EBPs that are in BH Connect or one of the EBPs referenced in FSP, reimbursement for that could look like pure outcomes-based reimbursement. Reimbursement for that could look like a mix of delivering the service and, in addition to that, a payment based on a financial incentive for achieving some sort of performance target. So I think the good news is, like, the sky's the limit. We can figure this out, and I think this is really like what Cal-Am Behavioral Health Payment Reform has unlocked. It has unlocked the opportunity for counties to design this.
Thank you. Commissioner Bunch is an expert, so I was getting a lot of her feedback and practice because she's actually implementing this, so thank you. The next question, you brought up commercial plans, but that's another thing because I want to know how are they being held accountable for this. But the other question was relative to procurement, and then I'm going to dovetail it with the TA. I found it encouraging that there's going to be these centers of excellence to support the existing workforce and the providers. But what are we're trying to fix a system that is doing some really good things and needing reform and needing more training. But what's the procurement process of bringing in new providers to do these things, testing models? Like if we are going to test if this works, are we going to test it with just the same providers? How do we bring in other people to see if this works? Because we need to broaden the pool, and we're talking about the staff, but there's no really clear understanding for me as someone on the ground that how people are able to provide even these grassroots services, because we're already just talking to the same people that we know. So is there anyone could answer that about the procurement process or to improve these programs? Or is that an outlandish question?
I mean, I don't know, Richard, if you have any comments on that. I mean, there are a couple of things that that's a lot. There's a lot of stuff going on here. I just want to just dovetail on some of the comments, and I would say, I'm glad you're in that role, Tyler, because what you're talking about really is critical and to help drive the system. I want to give an amen to Gary Sy and Barbara Ferrer for the work they've done in the Department of Public Health in LA County, because I think it's really tip of the spear across the system. Also, with respect to parity laws have existed since, I think, 2008 when Patrick Kennedy got them passed as federal law. but there has been no ability to hold private insurers accountable, and they're using a lot of public money to deliver care in a way that is just, in my opinion, unconscionable. We had a bill, I think it was SB 855, if I'm not mistaken, that was signed by Governor Newsom to go after the private insurers to make sure that they're paying. I mean, I don't want to get into the details, but we ended up having to sue a significant private entity who was dumping clients so that they could get IMD care, to the county. But I think what Richard said is really important. If we're doing really great work and the quality of the work is going up and we're achieving outcomes, the billing will take care of itself. And I think we can't lose sight of that. I think that's also consistent with what you're saying, Tyler. And I would say, Mark Galley always used to talk about MHSA being the caulk in the tile floor, keeping things together. And I think we can't lose sight of that because it is special funding and it has to be used to do those things that are required for cohesion.
So just to pick up on that point, that there's a clear observation that within the service right now, there is a deep level of inefficiency because they're not maximizing the time with people on the program, focused on their needs, focused on progressing them. They're spending a whole shed load of time on administration and paperwork and all this billing stuff. But we need to prove the concept, right? We need to demonstrate that we need to run a pilot for 2 years and go, stop worrying about billing, really focus on outcomes. And I'm not talking about the big impacts of incarceration, hospitalization. I'm saying we'll agree what the outcomes are that are meaningful for those individuals, and that's what we're going to pay you for. Now go off and deliver as many of them as you can. My background is running operations. You tell me to do that, and I'm really going to drive my frontline staff to double the face-to-face time that they have with people, to be 10 times more responsive. And that would increase the billability, but we've got to prove it. Which brings us on to your second point around the procurement. So we've been having this conversation with people in the state now for a good 12 months, maybe 18 months, and your procurement is a blocker. I'm afraid it's, people are really reluctant to engage in this stuff because they're going to have to engage in a 6 month, 9 month, 12-month process of a lot of work. We need to prove the concept. You've got to ask the question as to how you can make that procurement process easier. And there are organizations out there who are not the usual suspects. And this surely has to be part of if you want to challenge the culture within this service and shift it from process to product, you're going to have to bring in people who think differently, who aren't just going to do same old, same old. And they're out there. There are some brilliant, innovative organizations in this country who deliver performance and outcomes and are paid for it. But you've got to run an open procurement and invite them to come in and make it easy for them to respond to.
Say that I know that there's so many innovative people in California that we could probably tap in, but the country, learning out of the country is good. I just worry about us not bringing in but we know best ourselves too, as well, Californians. So I just want to make sure that I'm not promoting a whole bunch of service providers coming in from other states. And really we invest in our folks, but totally want to learn from lessons from other people. I appreciate the time and answering my questions.
That's cool. So my background really in this outcome-based stuff is employment programs, is helping people, supporting people to achieve jobs and sustain jobs that really address their needs. And this industry of mine all started in California with a book written by a woman here called Deborah Angel, and it's called No One is Unemployable. Because the dogma within the system was, I can't get you a job because of all of these problems. And she sets out in this book that there is nobody you cannot get into a job. Yeah, and that starts here. Okay.
Thank you. I'm going to invite Commissioner Danovich, who is online, please.
Yeah, thank you. Outstanding presentations, really exceptional panelists. And as I'm listening to them, I'm thinking just, yes, 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 and yes. And so I have a general question and then one particular question. The general question to each of you, and you could answer right now or you could answer after the fact, is if you had to choose one or two things that we as commissioners, that we as a commission can do to help you fulfill some of what you are proposing, what would you prioritize? What gets in our way sometimes is too much, and forests and trees. And so your help, helping us help you, I think would be really, really valuable, and welcome your guidance on that. And then Tyler, thank you for all that you're doing. I wanted to ask you in particular, with respect to FSP, I know there's a lot of interest in developing greater substance use specialization within FSPs. What is the state doing to facilitate that, and anything that we can do to accelerate, enable, advocate, ensure that actually becomes a reality?
Thank you, Commissioner. I'm happy to kick us off. I think from my perspective, my initial reaction is, how can the commission be helpful with respect to FSP specifically, is helping the administration and all of us collectively together shape out what does the continuum of care look like in FSP? What are those standards? What are those intensive, levels of care? Because what the statute does is it says in FSP, it shall include a few evidence-based service models that are specified, community-defined evidence practices, and then other behavioral health services. It also says there should be levels of care for people to step down. And I think what Susan from Fresno did was show how a county has already done this. I mean, that was like perfect, right? ICM is almost like a lighter version of ACT that seems to be another level of care, another service. From that, where do people go? This is a blank slate opportunity, and it would be really helpful for the state of California to have an informed discussion about what those levels of FSP look like, what step downs look like, based on what we know works today in our communities, in counties, and in the research. So that's my reaction to that. And then I think for the substance use disorder question, it's even more of a blank slate opportunity and more of a potential for innovation. If you look at the language in SB 326, it says that FSPs shall include assertive field-based initiation for substance use disorder treatment, including medications for addiction treatment. And I think what that language does is it reveals the fact that there is no standard service model for a substance use disorder like there is for assertive community treatment. There is no defined model. In the Medi-Cal, we've issued guidance on street medicine. We've issued guidance on medications for addiction treatment being billable at any site in the community. So we're providing, taking the barriers away and providing the tools for providers and counties, to cover and deliver SUD treatment wherever folks are. But what does that look like as a service model? What does it look like to identify what's the best practice in improving outcomes and engaging people? What's doable? What are the training and the qualifications? What does that look like to connect people to to clinics, to the California Bridge program? That's a massive opportunity. And I think we'd really be looking to you, Commissioner, and to this commission, and from counties and providers that are doing this today to help define what those service models are for assertive SUD treatment.
Emily, do you want to go?
Thank you. Commissioner Danovich, we're good?
Yeah.
Ask us all to-
Yes,
Okay.
I think that if others want to respond to the question about what can we as a commission do, what we should prioritize, would welcome that. And again, and if not now, then after the fact. But we want to work behind the scenes to help, facilitate these proposals.
Yeah, happy to speak briefly. I'll echo, Tyler, what you said about helping us kind of build out what those different levels of care could be. And the other piece that I'll name is, I'm not an architect, so COC didn't resonate with me, but fascia is really how I think about the OAC, where the OAC is a this connective tissue between the different programs going on in the state and helping us really build out our accounting of just the brass tacks. Who is doing this work? What are they doing? How can we build those literal linkages between different providers, different staff members across the state, just so we can start to have some of those conversations where we're surfacing those best practices.
Yeah, I'll try to be brief. And Gally's the one talking about the bathroom floor. I'm a medical doctor, so I appreciate the fascia. What I would say, Itai, is that there are opportunities for innovation money that's still in place before it kind of is removed. Not just for money that hasn't been committed, but for money that hasn't been spent that could pivot towards FSP, because whether it's meat and potatoes or fish and rice, it is the fundamental fabric of community mental health. So when those pilots are brought to you, or those innovation programs are brought to the commission that focus, and I'm biased, on using innovation money for outcomes, so that yes, there will be billing, of course there will be billing, we need to optimize that, but that allows for incentive, for payment, for achieving outcomes for individual people, that would be great. Bless those innovation proposals.
Can I come in as well? I'll be brief.
Brief.
Okay. 3 very, very concrete things. The first is, when I look at the FSPs, one of our challenges that we've got is actually defining measurable, standardized outcomes, because the individuals, their outcomes are completely different for all of them. So I think we should need to go and do a piece where we go and talk to people on FSPs, and we try and come up with a list of a dozen potential outcomes for people, a dozen potential outcomes for place, and a dozen potential outcomes for purpose. And then we use those to pay the service provider for achieving the outcomes that the individual on the program selects from that dozen. So it's my choice from that drop-down list, if you like. So let's go and ask them to do that. It's these people who know best about what the outcomes are. Second is, I think you really need to run this proof of concept thing. Let's see what happens when you take the shackles off and you focus on these people and the potential of these people, and let's see what billing follows. So I would go out to counties now and say, who would like to engage in this? And you come up with a facilitated process to enable them to do that easily. And then the third thing is, please, please, please start to think about transparency across this system. You've got to answer this question of who's doing it well and who's doing it badly, so that we can learn from that.
Thank you. I have a question. You said people, place, and?
Purpose.
Purpose, thank you. Okay, I have Commissioner Brown, Commissioner Rolette, Commissioner Bunch, and then Commissioner Mitchell, and then Commissioner Carnevale. Please, we'll go in that order. Commissioner
Thank you,
Brown.
Madam Chair. I'll try to make this brief. Thank you, panel. Great panel. Really appreciated all of your input. My question is about workforce challenges. And I see a lot of parallels with law enforcement workforce challenges as well, in terms of hiring the right people and keeping the right people on the job. My own observations, and I don't know if these play out with all of you, but I see a lot of people who are getting into the field as second or third career, going to school, getting degrees. They want to work in the field, but maybe not necessarily work 24/7 kinds of shifts and around the clock, and work in encampments and go into neighborhoods that aren't like theirs, and challenges like that. People that want to work doing maybe telemedicine or telehealth care rather than in-person, upfront and personal health care. Are you seeing the same things? And what we're trying to do in law enforcement is try to rethink where we're recruiting people from, and the traditional pools that we've employed for so long, are not really, particularly for our custody staff, are not really paying off as well. So we're trying to look at branching out, maybe looking at people that are in different, either students studying different subjects rather than criminal justice, as well as people that are in different fields like teachers and counselors and other fields as well, trying to see if they might be interested in a career in corrections. I'm sure you're seeing these same challenges. If my county's any indication, what are the thoughts in terms of how to either throw the net further and wider to attract the right kinds of people, and then once you hire them and see them, how do you avoid the compassionate fatigue, the burnout, and how do you keep them in that role?
This resonates very much with me, both from my hat as third sector. I also used to work in permanent supportive housing, so very similar set of issues. A couple of things that we've seen from the field. One is balancing the fact that FSP services are best provided in person, and as our colleagues and friends said, in the field wherever people are, literally, and balancing that there are aspects of the FSP jobs that don't need to happen in person. And so thinking innovatively about, are there shift styles or kind of work arrangements where X number of days you're in the field, but on Fridays is when you do your paperwork from the comforts of your living room, whatever the case may be? Or are there rotation programs where for a certain amount of time you're working mainly with more high acuity or more high stress cases or situations, and then you have a period of time where you're working in a less stressful situation, and so you're able to balance your compassion load and do a little bit of self-recovery. We've seen a couple of counties begin to speak to some things that they've tried there. Two other things that we are seeing and would recommend exploring further, especially in our further conversations with counties. One is really leveraging peers in extensive ways and working to see, looking at the workforce of folks who have graduated from FSP programs or participated in other parts of the behavioral health ecosystem as potential partners here, and also looking across the allied health professions, particularly social work schools, looking at internships and pipeline programs, and considering ways to incentivize participating in FSP there. So very much echo pretty much exactly what you're saying over there.
Three quick responses. First off, and I find this really interesting, it's not the same everywhere. So we're making a whole bunch of assumptions about why we've got workforce issues, but I will go to the same town and visit two service providers, and one of them is going, I can't recruit people here to save my life, and the other one has got no problem with recruitment. So what's going on there? Second is, the more we move towards a high fidelity model, the more this is going to become a problem for you. Because you are demanding that the service provider delivers a particular model with a particular sort of person with a particular set of qualifications. And you are tying their hands. All the stuff that you described within law enforcement that you're trying, you need to liberate the service providers to try those things, to play around, to innovate, to bring in different people, to use different delivery models. And the only way you can do that is to shift from heavily prescribed inputs, which you attach the payments to outcomes, and enabling them, freeing them up to focus on the needs of the individual and configure a service as best fits around that. And the third point, which we've already said, is you need to take the billing away from these people. They didn't join the service in order to be ticking boxes and submitting claims to Medi-Cal. John?
Yeah, at the risk of being redundant, I mean, I did street psychiatry in LA County, started a program. I had to get someone to help me do the medical chart and billing. I couldn't figure it out. He's a psychiatrist now who's now in the street psychiatry program, Shai Rab. I think there's some really important kind of consistent messaging here. The workforce needs to be reconsidered. Half of the problem in our space is engagement, initial engagement and ongoing engagement. It's not about, clinical degrees. It's in many ways, it's about lived experience. It's about shared understanding, respect, and sensibility. So we have to really reconsider that. And we did pass SB 803. Is that what it was? The peer, right? Mm-hmm. After like 4 tries? Well, I don't even want to go there because that was painful. But that's a big, big deal. And being able to reimburse, the Fed for peer services is huge, and it has not. We need like a brigade across. Yes. And then, lastly, again, as I think we're all saying, and Richard is saying, if we're paying for outcomes and people are liberated to do the work that they came to do, people are going to stay. It's more important than how much they get paid.
I think
Commissioner
Susan,
Roll, I'm sorry. Susan, please, if you'd like to respond.
May I? I had responses for each, but I know time is limited. But I do agree with what my colleagues have said about workforce. And as I stated, we were in a workforce shortage, long before we were talking statewide about workforce shortages. Here in the Central Valley, my colleagues in Kings County, Tulare County, Madera County, Mariposa, they share the struggles that Fresno County does. I think it's really important that we think about retention of our workforce in similar ways that we're talking about our full service partnership programs, right? Connection to meaning and purpose. That's not just good for the people that we serve. It's great for our team members. It's great for our administrative team members. We focus a lot on clinicians and doctors and nurses. I have passionate administrative staff who are also burned out, and we need to retain their expertise. They know the regulations better than I do. I'm embarrassed to say that out loud, but they do. It's a fact. I need them. I need their expertise, but our system is burning and churning, if I could be so bold as to use casual language. And so we really need to connect people to purpose. I think leaders like myself have to be able to slow down enough to focus on organizational well-being, which is different than individual humans having wellness. Organizational well-being requires us to invest in conversations that allow for truth to be lifted up and experiences to be shared openly, without the fears and pressures of things like productivity, as was mentioned previously. And then I'll share that in Fresno County, one of the speakers commented about engaging, I think it was our colleague from Third Sector, engaging with the universities. We have a long-standing practice of taking students in our programs here in Fresno County, and really excited to see the state bringing forth the information to us to be able to claim for those services for those graduate students. And a lot of us in the field, even though we're super tired and exhausted from our day job, I teach a class at Fresno State here in our community because, number one, I want to give back to my community because that's where I became a clinician. They trained me. And I want to raise up the next generation of helping professionals to talk in person-centered language, to understand what recovery means, to understand that I don't want them sitting in an office with four walls and dim light and a candle. I want them out in the community, sitting on a curb, having a conversation about recovery with somebody that just got out of the hospital. And so we've got to connect to purpose. I know you could probably hear a little bit of enthusiasm in my voice. I get super fired up about this, but we've got to figure out not just recruitment, but retention. It's critically, critically important. And I know you probably don't have time for me to give responses on the other two questions, but if there was time, I have those as well.
Thank you, Susan. I'm going to move on to Commissioner Rolette, please.
Thanks again, and I'll also be respectful of the time. First, full disclosure and context setting, the organization that I'm privileged to be a part of, Turning Point, is the full service provider in Nevada County, and also provides FSP services in Sacramento County. And so fully acquainted with some of the unique challenges and agree with what you said about the challenges. So I'll try to ask a question that doesn't typically get asked, and that's pertaining to the managed care plans. And Tyler, you talked about that. I think you referenced their capacity, even capitalization, and their lack of engagement from the perspective of one related to providing care and service and support for individuals that are enrolled in FSP programs that might be or should be eligible, and in fact are determined to be eligible, but still are served in varying ways depending upon the plan and the tenacity of the case manager with the FSP. Because most of the FSP participants don't understand or appreciate the full utility of their Medi-Cal benefit. And that's our job, to help them appreciate that, to get to those 12 questions that you really clearly articulated. What would you recommend the OAC do to engage managed care plans around the state of California in helping ameliorate or bring light to what I think is an opportunity to enhance FSPs?
Yeah, thank you, Commissioner. It's a great question. And I think, so I think what BHT does a couple things, and I'll highlight those, and then I'm happy to talk about opportunities for the commission to engage. I think what BHT does is not only call out that managed care plans as well as commercial plans have, sort of for covered services, an obligation, to reimburse, and that counties are expected to sort of seek that reimbursement and leverage those funding sources. What it also does is the process for the 3-year integrated plan for behavioral health services and outcomes is under behavioral health transformation. It's evolving from a 3-year MHSA plan to a 3-year integrated behavioral health plan, where the county not only looks at all sources of behavioral health funding, but also takes into account the managed care plan's population needs assessment and local public health departments' community health assessments as well. Because the goal is to break down silos and to have cross-system coordination and alignment, so that the 3-year integrated plan for the counties is inclusive of and reflects as an informed by what the plans are finding and identifying as needs in their assessment, and vice versa. We're requiring the managed care plans to, so coordinate their process for their population needs assessment by taking into account the county's 3-year plan. So that's just sort of high-level references for how behavioral health transformation brings the Medi-Cal managed care plans into the picture. I think that under CalAIM, the enhanced care management benefit, which is designed to be, in person, as this panel has shared, high touch in the community, meeting people where they are, delivered by community-based organizations. That's a really powerful tool. And I think everyone in FSP, not everyone, many of them are likely, many if not most, are likely to meet one of the enhanced care management or ECM populations of focus. And that's a benefit that's eligible to them that would really be a lead care manager that is tasked with being the quarterback to drive engagement with medical benefits, with social services. So I think that's a key opportunity. And I think, OAC could invite Medi-Cal managed care plans here, could invite the plan associations here and say, talk to us. How are you engaging our population? How are you really leveraging ECM as an opportunity to engage with the FSP population? These are conversations we actively have with plans, and I think OAC inviting Medi-Cal managed care plan representation into the dialogue could be pretty powerful.
I appreciate that. I would hope that Toby and staff would consider that. It would certainly be an intriguing conversation.
I'd second that. That wasn't even a motion.
Thank you. It is noted. We're going to move on to Commissioner Bench's question, please, Commissioner.
I just wanted to briefly comment on the workforce issues, because many times when people leave their clinical positions, it's not because they've decided it's not a good fit. It's because they get frustrated with an inability to provide quality care under the constraints of the systems that we work in. And that's what I've learned just from being a supervisor and from being a clinician. And kind of in regards to that, I was curious, Emily, did you guys look at staff turnover in your outcomes? And also, are there currently any metrics that look at the positive events? And my question is from so far away, I hope you remember what I'm referencing.
Just to clarify, the positive events on the staff level, or can you clarify that question?
That we need to look at, in looking at outcomes, we have to look at the positive events.
Yes.
And so I'm just curious if there are currently any metrics that look at positive events.
Yeah, so that's a great question. On some counties are currently doing that, integrating positive events in their metrics. The main thing that we learned is that while there are bright spots around the state, it's not happening consistently. And so even among the counties that we worked with in multi-county, the 10 counties that we worked with, many of them did add community engagement was the definition?
It was increased social connectedness.
Increased social connectedness as a positive outcome to focus on. And that actually came directly from consumers themselves. And many of the counties that we work with are integrating that. Much more to do and much more to think about what is that list of, is social connectedness the one, or are there other things? The other kind of asterisk I would put on that is thinking about what a positive outcome looks like in someone's lived experience, and noting that if an individual is experiencing a lot of churn in and out of carceral systems or in and out of hospitalization, ending that experience has major positive impact on their day-to-day life, on their ability to feel free, live with dignity. And so part of the outcomes conversation that we hope to have across the state is both doing that tracking and doing that framing to understand what are the what does that look like at a human level to experience both affirmatively positive outcomes and those lack of negative outcomes.
It's almost like it would have to come from the clients because, working with a client where their positive outcome is, oh, I got out of the house, 2 times this week instead of 1 time this week. And a lot of times that we're not measuring the minute things like that are making such a difference to the clients on an individual basis. I'm sorry.
No, don't be. So I understand, Tyler, you have to leave now. So we very much are thankful that you were here today and sharing your expertise with us. And hopefully we will have you return for additional dialogue and conversations with us. We will continue this conversation. I know we are running late, and so we apologize for that. But Tyler, again, thank you. I understand you have to go. So thank you for being here.
Thank you, Commissioner. And I apologize to the Commission, and I apologize to members of the public. I really do, unfortunately, have to hop, and thank you for your understanding. And I wish it were not this way. I would like to stay. Thank you.
Yeah, no problem. We'll see you at a later date. Hopefully
Can I pick up on the question there with an answer? So at the moment, we're somewhere away from being able to say these are the 12 things that we could have for people, place, and purpose. But in Nevada County and in Sacramento, in this performance pack that I talked about, where the service provider, the case manager, is going to ask each person that they work with 3 questions every month. And we're going to use those 3 questions to ask them about the quality of their experience in that month and whether they're progressing. So we're going through the process now of trying to work out what might those 3 questions be. Because they've got to be accessible. They can't be full of jargon. They've got to actually be meaningful to the individual. And we want the same 3 questions asked to everybody every month. And we're going to capture this data and track whether that changes over time. And also in the process, nudge the case managers to be engaging in a different sort of conversation. So we think the questions might be, are you feeling better, worse, or the same? Something like that. Has the month been better, worse, or the same? We think one of the questions might be, are you looking forward to your next meeting here? Because they've got to want to come. They've got to have a sense of trust and engagement. And the third question might be, did you do something new this month? And that new thing will be completely different for different individuals, but are they actually engaging in something new that is moving them forward and progressing them? And we're also going to ask all of the staff 3 questions to try and understand their experience, their motivation, their morale, and again, track this over time with the service providers.
Just real quick, when I was in the VA, we developed what we called the RCA. So root cause analysis is usually used to figure out what happened in a sentinel event. And if you apply that to recovery in a case where it's profound, you can learn a lot about what it is in the process that's leading, what's the root cause of that recovery.
Thank you. Commissioner Mitchell.
Good morning. I'm going to keep this short as I can, but I and it's probably not a question, it's just a comment. I'm so appreciative of this presentation, Dr. Sharon. I absolutely agree with you 1000%. I think maybe the first time since 2016. I mean, I so appreciate this presentation, and to you, Richard, as well. And I think I'm so touched by it because in your study, just what you called out, because as over the years, my comments have always been on the ground for the people that we serve, because that's really what it's all about. I do think CalAIM has done some wonderful things to kind of measure us being on the ground more, spending less time with all that paperwork and documenting mileage and how much time it took to write that clinical note, but how much time we actually spent with that actual youth or family. So I absolutely appreciate the fact that you called out. We are, I would say overall, not really doing the greatest on good, or we're not doing that good on purpose. And so in our outcomes, we really, and this is why I would like the commission to go in helping to develop this thing, is to really, when we look at outcomes, is to really measure outcomes on the individual and their improvement in their life. Like, that's really why people come into service, because they need help. I mean, it's real simple. The system is so complex. We spend so much time on that paperwork and meeting those billable services and designing that note to meet that thing that's billable, which is, we understand it has to happen because that's what we built that system. So we've got to really design a system and the measurement of the outcome of that system on the purpose and the goodness of that individual who has come into service. So many wonderful things were said. So I won't just talk, but I do think that incentives, whether it's for the counties to receive incentives or for our individuals, the incentives have to be based upon the improvements in that individual's life. We say it all the time, our clients have the answers, they know what they need, they do. We just have to teach them to use the tools that we're trained to utilize to help them make better choices, make better outcomes in their lives. But our clients, they know what they need. It's just all the barriers that come into play to why they don't do that. But we are the authors. We should be able to help them use those tools to have better outcomes. And so I would just love to see a system that's built on a standardization of measuring the improvement in that person's life, whether that's one question, two questions, three questions, and also to not ignore the experience of the individuals. How did your experience in the system, how were you impacted? Because we do know that, again, people of color have a different experience. And so the system has to take those things into effect. But to me, it's just super simple, but we make it so complex with all of these billing requirements. We have to hit that threshold. And really at the end of the day, was this session helpful? Did this move the needle any? And it's just such a basic concept, because we're running in, we're running out. We do what we do in that hour's time, half an hour time. And did we move the needle at all in that person's life? And we do this for whether it's 6 months, whether it's 10 months, whether it's 16 months. And I wanted to ask Tyler, have we incorporated the child welfare system in this discussion too? because many of those individuals are the ones who come through this door. And so, again, these are just my thoughts, because my brain is just so full based on your discussion this morning. So thank you, Richard and Jonathan, for the beautiful presentation, because I really think you called out some things that we have to take a look at for Californians to really have improvement in their lives, because that's really what this is about. It's about us getting into this work and then staying true to the purpose of the work, and that is we want to see people's lives improve. If we really care for our mankind, we've got to do better about the services we perform, not running in, running out, and going back to bill it.
Thank you,
We've gotta do
Commissioner.
better. So thank you.
Thank you, Commissioner Mitchell. Commissioner Carnevale, then Commissioner Gordon, and then we're going to need to move on to our general community.
Thank you, Madam Chair, and I agree completely with what Commissioner Mitchell said, and I appreciate my fellow commissioners who are working in the system and understand the details of it. As a business representative, I think of this more at a system level, and I know this is really unsexy work, but this is such essential work, and I'm sorry we're spending so much time on it, but I think it's so important. You know, my analogy here is that this is like the plumbing in a house. And when you walk in a house, you don't even think about the plumbing unless it's broken. And then it's the only thing you think about. And it seems like this plumbing, I'm not sure if it ever worked, but it's broken in so many ways that, you know, it makes the house unlivable. And, you know, business struggles with this too. Big business, all big organizations struggle because they have complex problems and a lot of people and it's hard. But, you know, business seems to come more naturally to these solutions. If you pick up 1,000 Management 101 books, it's all about outcome-based management. That's how you get to better organizations, and the organizations that thrive do this, and ones that don't go bankrupt. It's as simple as that. You know, I picked up from Dr. Sharon, if we have performance management systems plus a robust data system plus some kind of payment and billing innovations, that's the 3 steps to transforming our whole system. And that's what I think people want. And, you know, we're in the middle of this national debate where it seems like half the country wants to, you know, tear government apart, and the other half of us are trying to make it better. But this is a great example of where we struggle to make it better. And so that's why I think this is such an essential thing we do. And I was going to ask Tyler, I mean, he's talking about moving from the Stone Age to the Bronze Age, and I'm thinking, you know, we're already in the information age, moving to the knowledge age of with AI. And so I guess and I was going to ask him this, but I'll ask Dr. Sharon, even though I know he's very modest about his opinions. Why is it, explain to my mother, why is it that government doesn't naturally come to these processes? Why do we have to fight so hard to get to them ourselves? And is this truly what will transform the system? And how long can it take? How long should it take? How long will it take so we can actually fix this plumbing issue, so we can get focused on the real issues of prevention and early intervention?
Well, I mean, that's a big question, Commissioner Carnevale. And, you know, I would say that very, very well-intended efforts at the top, at the grass tops level, have led to a significantly fragmented system of programming, of data collection, of funding. And it really is only if you're focusing on the consumer, which you do in the private sector, and how you can actually attend to those needs and build the system around that you're ever going to succeed. So there are all of these kind of what I would call vestigial structures, it's a medical term, are in place, and they have to, some of them be dismantled. They have to be dismantled very carefully. And I'm a restless person. So I'm the last person in the world that wants to take too much time to do things. And I think the way to get that alignment going straight up, grassroots and forming grass tops, is to just say, what are the outcomes? Pay us for the outcomes. And then say to the White House and say to the governor, facilitate our success achieving those outcomes. Where are the carrots, not the sticks? Pushing us as a system to just, for doing the same thing, doing more of it is a big, big mistake. And I'm worried about that with CalAIM and frankly with Prop 1. So we have a window in time to reverse some of the things that might happen under the same rubric of legal language to drive it from the bottom up based on what you do at Procter & Gamble. Take care of your customer and let them define and drive the system.
Thank you. I'm going to move on to Commissioner Gordon, please.
Yeah, I will be brief. I wanted to ask some questions of Tyler. But my wonder in all of this, and I think the finding employees and keeping employees, I think a lot of it's based on culture. I think the services to people are based on trust and access, and managed care doesn't give much hope on either of those things. But most of all, I think someone working in the field is looking backwards from the service they're providing and say, is help on the way from the standpoint of, as Steve said, in terms of prevention and early intervention. And we don't do very well with that. In Sacramento, we have 4 separate managed care plans. And they're all, the governor with the SB HIP program, we work very closely. We have a great relationship with all 4 managed care plans. But the clients are randomly distributed among the 4 managed care plans, and there's no plan to reach down particularly into the underserved areas. So the problems we have now just replicate themselves because there's not enough, if anything, going on there. So I think we need a strategy alongside the strategy to intervene with the people who need the most services. And I think that's something that the commission is uniquely positioned to try to think through. How can we reorganize that service based on data and based on accomplishment? Some of the first 5 commissions are doing that around the state right now, and they have lots of data. So, for example, in Sacramento County, 65% of the families are in managed care. So I think there's both a problem there, but there's great promise if we can think that through in conjunction with amping up the quality of the services, the downstream kinds of services. So,
Thank you, Commissioner Gordon. I want to thank you all again for your presentation, for sharing your knowledge with us. We definitely want to stay on top of this, have further conversations as we go forward. I would just like to say, for children and youth, we want to make sure that we're considering schools as partners. We didn't hear enough of that, and so I'm just going to put in a plug for that. And Susan, thank you so much for your participation. I appreciate the candid conversation and the words, burning and churning. It is exactly right on. And so I think as leaders in the community, we need to be really thoughtful about our organizational well-being. And if we're not addressing that, no matter what systems, measurements, outcomes we put out there, we are not going to have the workforce healthy enough to do the work. So appreciate that truth right there. And one more thing, you're right. I think about it, the diffusers and the dim lights. No, I want somebody out on the street talking to real human beings. Human beings, we're messy. And, we don't need the sterile environment. Just get real with me and take care with me. So that really just touched. So thank you. Thank you for that, Susan. We are going to move forward to comments, members from the public. So you may request to make a public comment on agenda item 5 by clicking the raise hand button on your computer or the app, or if calling in by phone, pushing *9. Are there any public comments on Mariani? Please raise your hand now as the queue will be closing.
We currently have 3 virtual comments. The first one is from the phone number ending in 319. Your line is open.
Yes, this is Steve Leone. Can you hear me?
We can, Steve. Please go ahead.
Thank you. Thank you. This is a powerful presentation, and I'm much encouraged, particularly by Richard Johnson and Jonathan Sharon. But I wanted to bring up some concerns I have with what's in the new law, Prop 1, around full service partnerships that could undermine a lot of this. And in particular, I wish to mention, the step down within the full service partnerships. Now, if you, by that you mean like stepping down or out of the partnerships, but in San Francisco, Newsom came from San Francisco, he's mayor there. And in San Francisco, my old home county, they do things with a lot of step downs. That's their system. So it doesn't surprise me that he brings the San Francisco system to the state. And oftentimes in the city, you talk about step down, meaning cheaper beds. You move from one bed and you get better, supposedly. You move to another bed, it's less expensive, et cetera, et cetera. So the support system you have around you keeps shifting. And I don't think that's a very good way to go. And in particular, I wanted to mention that in the law itself, it says that the step downs shall be based on acuity. And you say, well, what's wrong with that? And that is that in the original MHSA, and this is something that's been pointed out by Dave Pilon, I believe you heard from him some months back, that the stepping down in this case was stepping out of the full service partnership was based on something called milestones of recovery. There could be other instruments, but it was based on recovery. So what does that mean? Recovery means whether or not the person has begun to look after themselves, wants to take their medication for their own reasons, and is willing and able to make connections to keep a support system around themselves. It's not based on acuity, which means that we've stabilized you on medication, and so we pull you out of this environment and you move it down to somebody, a lower environment. And the person, doesn't like their meds anyway, and so they go off the meds. And so we go round and around. And where have we seen that story before? So I'm very, very concerned that this basing the step downs on acuity, whatever the step downs mean, is going to be contrary to just doing as Richard Johnson said, to doing it for people's own benefit, for what they need and what they want. That's the cornerstone of the original FSB in the MHSA. And I don't want you to forget that stuff. And there's more, but actually, if I got a couple minutes more, I'll say, a lot of people say things like, currently the MHSA is just supporting. Hello? Are you still there?
Yes, we can still hear you.
Steve, your time is up.
I wasn't
though,
sure
so
there
if you
was
could please
an
wrap up.
interruption. I wasn't sure that was. I was just saying that people say, that never mind. That interruption just screwed everything. So I'll talk to you about it later, hopefully.
Thank you, Steve.
The next comment we have is from Steve McNally. Your line is open.
Thank you very much. I do appreciate the presentation, and I'm a family member with a son with schizophrenia that all his personal relationships with family have been reconnected, which I'm very appreciative of. I think the further we get away from the state of California in this conversation today, the closer we get to community members and focused on the end user or our loved ones. And, recovery is based on, willingness to change, trust, honesty, and openness. And I think the two gentlemen, John Sharon, really appreciate, since I first met him in Santa Monica at a town hall, I made a comment. They're really simplifying what's required, which is a culture change. And the state, I think, needs to come to grips with this, or we all have to come to grips with this, because families have been distanced from the system. And peers, we have 3,300 of them that are currently certified. And I heard we talking about what we want to hear from peers, but I'm not aware of us actually talking to the 3,300 people that are certified or where their workflows are going to be. So I guess it's really hard. It really comes back to accountability and oversight. And even Cal-AIM currently, while the aspirations are incredible, I don't think the implementation, from what I've been hearing in different meetings, is all that smooth. And then as far as data, Toby had once made a comment to the Behavioral Health Planning Commission that there is lots of data, but there's no appetite to look at it. And if I could get one thing suggested, would be to take the open access, the open data portal, and create county level data there. Because the people who can provide county level data aren't currently doing it. And all that's going to require is a little bit of programming. And Department of Healthcare Services has, I think, over 600 data sets. They may not be the right data sets, but certainly we could empower that from being raw data into county level data for comparison. So again, I appreciate all the comments. It's just so hard to watch when I know it's a very difficult population to deal with. And it seems like our issues in California are very chronic. And it really comes from not listening from the bottom up, from my vantage point, and knowing that they work with the hardest people. And yet we can't seem to be connected.
Thank you, Steve. Your time is up. Please wrap up.
Yeah, I will wrap up. I don't mean to ramble, but I just think getting back to focusing on people, relationships, one connectivity point at a time is what really moves people. And I think we're just lose sight of that, just looking at increasing billing. So thank you.
Thank you, Steve.
And our last public comment is from Kayleen.
Good afternoon, Commissioners. This is Kayleen Gilbert. I am the MHSA coordinator for Los Angeles County. I wish I could be there with all of you in person. But I really do appreciate the OAC bringing this conversation to the table. It's been a super rich discussion, and we did implement our incentives program for FSP back in fiscal year 21-22 under Dr. Sharon's vision for engagement, for retention and outcomes, and we have paid those out over the last couple of years. But, we're looking to grow the program, but wanted to share that we've also learned that a lot of careful thought has to go into the determination of that incentive criteria. And we've learned that it takes time to develop and put in place the dedicated resources you need to make sure that those robust incentive systems allow providers to monitor their performance and make those adjustments along the way. So we know we're going to continue to learn a lot through that process, but we see this as a really useful tool, particularly as we move towards the VHSA Act standards and the levels of care. So thank you for your time.
Thank you.
That was our last official public comment.
Thank you. Thank you, everyone, for your public comments. Again, thank you to our panel for being here. It's a long time to be here and lots of questions, but we greatly appreciate your time. So with that, we are going to, Commissioners, we are very pressed for time this afternoon. So we are going to take a 10-minute break. There is food in the lunchroom. We are going to ask that you grab your food, bring it back. We will lose quorum at 2 p.m. and we have 4 innovations that we need to listen to. And so please, I'm just asking for your collaboration and cooperation on this. 10-minute break, grab your food. We will do a working lunch. We want to make sure that we take care of those communities. So see you back here in 10 minutes. Thank you. We are on to agenda item 7. It is on the topic of innovation and how it will change under the BHSA. As you remember, at the April Commission meeting, I gave direction to staff to work with Commissioner Rolette to identify recommendations on how we can support counties in ensuring that innovations that come to us support the spirit of BHSA and are sustainable given revised BHSA funding streams. After Commissioner Rolette shares his recommendations, the Commission will hear presentations and will consider innovation proposals from 4 counties. Commissioner Rolette, the floor is yours.
Thank you so much, Chair, and to my fellow commissioners. The Chair charged me with the task, and I want to begin by acknowledging that I also learned a lot about the unique attributes and wonderful skill of the staff on the commission. I want to call out, if they're here, for them to stand or raise their hand, stand if they can. Grace Reedy, Kara Starbird, Shannon Tartar, Jinga Shah, and of course, Tom Orick, Deputy Director. I want to thank you all for your wonderful, stellar support and your commitment to innovations and the work of the Commission. In particular, I know that some of the staff were uniquely challenged by my different style, Chair. That said, I do have 3 very specific recommendations that I will be discussing with you today. The recommendations are as follows. First, that counties include information on how their project aligns with BHSA, including sustainability, given the new funding categories for BHSA. Second, that you, the Commission, may want to consider how innovation dollars can be used to provide services to individuals who do not meet FSP criteria, such as those through adequate step-down services. And some of that was alluded to today, but certainly part of your consideration when you are hearing about these projects. Third, that you provide specific information on how the project will be, that specific information be provided to you on how the project will be sustained, given the new funding allocations of BHSA. Specific to reversion, since we are quickly approaching the end of the fiscal year, that always brings up the topic of reversion, and as I learned to understand it better, unencumbered funds. Staff have calculated through estimates from county data that will help us get a snapshot of innovation funds for the end of the fiscal year that are unencumbered. And the estimated unencumbered funds should be considered by the Commission, again, as it is should be a part of not only a discussion, but an ongoing presentation by staff to help the Commission help chart a course that will ensure that innovation accomplishes the most important goals that it was designed to accomplish in the beginning, and the new goals under the Prop 1 or BHSD. Information on the proposals being brought forward today. Out of the 4 projects that you will be hearing today, 2 are to join previously approved multi-county learning collaboratives. One is an extension of a previously approved project, and one is a brand-new proposal. Staff have worked with the counties, and again, I want to highlight the work that the staff did in this area. Staff has worked with the counties to ensure that BHSA, I think I said BHST earlier, BHSA. BHST is a very specific acronym used in my line of work. BHSA alignment and sustainability have been considered. This work includes meetings and feedback on all areas of the proposals, including areas of need within the county, community stakeholder engagement, and areas of learning through this innovation proposal. Consequently, based on my discussions with staff and my review of the 4 projects, I am recommending to my fellow commissioners that these 3 recommendations be that they indeed listen to the staff recommendations and support the recommendations by staff, given the projects that are coming forward to the Commission today. I want to conclude again as I began. It was delightful, absolutely delightful to work with staff. I learned an awful lot about innovation and the dedication associated with the projects that are being brought forward today by the counties that are proposing them. Dedication might not be the best word, but it's the one that comes to mind now when you eat your lunch really fast. But more importantly, as we begin to think about BHSA going forward, staff really has helped me to hone in on those key questions that we should always be asking about any innovation proposal that's presented to us from this point going forward. With that, thank you for charging me with the task. It was a pleasure.
Thank you so much, Commissioner Rolette. And I agree with you 100%. I think anytime a commissioner has a chance to work closely with staff on a project, on something like this, we get to know the skill set of our staff, also see their dedication, and learning alongside them is really a privilege. And we just get to see the heart and soul of our team. So thank you for doing that, Commissioner Rolette. At this time, we are going to move forward. Now we will hear from counties about their innovation proposals. We will first hear all the innovation proposals and then hear commissioner comments and questions. Commissioners, please jot down your questions about individual innovation proposals so that we can ask questions after all the counties present. We will also have separate motions for each of these proposals after we hear them. I would just like to note what Commissioner Rolette said. He has reviewed and worked alongside staff, and they are recommending that we move forward with these. So in the sake of time, I think one of the things that we've come to really work on is just trusting each other's expertise. So want to just make that note as well. So we are going to discuss the proposals. We've asked presenters to also discuss the project sustainability and BHSA alignment. So Ventura County and all counties who are presenting today, I would just ask that you really please adhere to the time allotted. We want to make sure that everybody gets heard, and we want to make sure that we have a quorum to vote for all of the counties and nobody misses that opportunity today. So let's start with Ventura County. I'd like to invite Julie Glantz and Tara Neendam, I hope I pronounced that correctly, to introduce yourselves and go ahead and get started. Thank you. Cody, are we good? Cody's like our Wizard of Oz.
We're working on it right now. Thanks.
All right.
Cody, can you hear me?
Yes, we can hear you.
Great.
Tara, can you say something again just so we could check? Julie, can you say something?
Hi, I'm Julie Glantz from Ventura County.
Okay, perfect. We can hear you. We are just working on getting audio for Tara. In the meantime, if you want to go ahead, Julie.
Do you want me to introduce myself, or Tara's starting the presentation for Ventura County?
Oh, okay, sorry. Oh,
That's okay.
Tara, I think I heard some sound come from, can you say something?
This is me. Can you hear me?
It's like, it's very faint.
Very faint.
Okay, that's a little better now. I don't know.
Okay. You can hear me now?
Yes, we can.
Yeah. Okay. Julie, do you have the slides, or does the OAC team have the slides?
Yes. Sorry.
Great.
Sorry, let me get
Thank you,
that.
everyone, for your patience. I guess while Julie's pulling up the slides, I can introduce myself. My name is Sharon Needham, and we are very excited to be partnering with Ventura County on the Learning Healthcare Network. They're interested in joining this previously approved project. Julie, do you want to start the slideshow?
Can you see the slides? Sorry, can you see them?
Yes, we can see them. If you want to go up to slideshow and see it in the top, the file bar right there, the top bar. Top, tippy top. Go right.
Sorry. Right here?
It's okay.
No.
Go right. Nope. Keep going. Keep going to the right. Right. Keep going.
Way right?
Keep going. Up. Nope. In the middle.
I also have them in the room. I can advance them for you if you just want to say next slide as you go along, or
Yes, Cody, let's
whatever
do
you
that
prefer.
because we are not going to have enough time. So if you can advance the slides
Right.
for them.
Sorry about that.
All right, let's.
Okay, great.
Okay, thank you. We're going to go ahead and get started. Cody will advance the
Okay, great.
slides. Thank you.
Thank you, guys. All right. So for those of you who may remember this project, this is something that we brought to the commission back in 2018 and had 5 original counties. And since that time, we've been growing across the state, which is incredibly exciting. So we are, Ventura County is joining this innovation project to expand our learning healthcare network for early psychosis care. And so as you all might remember, we co-designed a data collection platform to really enable consumer and family level outcomes, the collection of that data and the presentation of that data in care so that clinicians have data at their fingertips to help make decisions, kind of apropos of the conversation that was just happening. In this program, we also provide technical assistance to the providers so that they know better how to use data in care. Next slide, please. And so here is an illustration of that data collection platform where, again, we use a tablet-based or web-based data collection for service users and family members. And we do that in threshold languages to really ensure that folks are able to participate. That is ported forward to a provider level dashboard. And we have visualizations that we've co-designed for both providers and clinic level staff. And then at the top level, data is stripped of almost all of the identifiers for state level reporting. And it's been such a wonderful collaboration with our counties to support them in their reporting to the state and to other important community members, because that was a real challenge for our county. So it's been a really wonderful collaboration, and we're very excited to have Ventura join us because they bring a great deal of experience in this space and have already contributed a lot to our understanding within California. Next slide, please.
Yes.
Julie, I'm going to let you take it over.
Okay, thanks. Yes, I'm Julie Glantz, the Senior Manager here at Ventura County, and we've been fortunate to have our VC-POP, or Ventura County Power Over Psychosis program here for a couple years already, which has been a really great opportunity to serve this population. But what we're seeing is we need to expand and increase the size of our program, as well as joining the efforts with the LCHN project. So our hope is to be able to increase the number of clients we serve countywide. We will need additional staffing in order to provide the appropriate ratios to really meet the needs of this special population. And we're currently serving only starting at about age 15 and up, and we also need to lower the age eligibility to the age of 12 in order to ensure that we can meet some of these clients' needs at an earlier onset and get them before they're at a higher acuity. We're excited to have an opportunity to get even more data and outcomes so that we can incorporate that into our direct service with our clients and collaborate with Tara and her team in helping us to make really good program level decisions as well as a result of this expansion in this project. Next slide, please. In alignment with BHSN, the VC-POP, our VC-POP program is our only department's early intervention for psychosis. And as noted, we have very high acuity clients that we serve in this program. So one thing that we've seen is that we need to expand the program in order to meet the case rate here in Ventura County based on the state calculator. We're only serving about 150 clients currently, and we see that we can be tripling those numbers very easily here in Ventura County. So our hope is to be in alignment with best practices and the case rate within the county, to be able to expand to meet the needs of this population. And as I mentioned, it's in alignment with our future BHSA innovation. When the innovation funding is expended, it'll be in alignment with the future of BHSA for early intervention for psychosis. Next slide, please. This is our budget request. As you can see, we're hoping for just over $10 million of innovations funding to fund the program so that we can move forward and expand to meet the needs of the county and the community. Next slide. If we're going to wait for questions till the end.
Thank you. We don't have any questions. We're going to go ahead and move on. So let's move on to the next county innovation proposal from Fresno County. Ahmad, please go ahead.
Thank you, Madam Chair. And I believe they're going to share the slides with perfect. So go ahead and go to the next slide, please. So just real quickly, this is a refresh of an existing program that your commission approved a couple of years ago. We're going from a 3 to 5 year plan. And really what we're trying to do is to continue to explore the model for sustainability with the community defined evidence practices. Next slide, please. So, and I'm not going to read the slide, so I'm going to leave that for folks to be able to see. But really what we're looking at is the initial CRDPs were created at a time where they didn't really factor in how they would align with county funding. CDEPs were setting to sunset several years back, and we really felt that they were vital and wanted to make sure that those keep going. And so we came forth with an innovation plan to really explore the sustainability of CDEP plans, specifically using MHSA's PEI component. As we're well aware, PEI is going to shift, and BHSA redesigns how MHSA, what was MHSA, BHSA will be utilized. And so that poses again a challenge for sustainability. So what we're hoping to do with this extension is to continue to really look at ways that we can create a roadmap and a model for sustainability, not just for the 3 CDEPs in Fresno County, but also for those CDEPs statewide, as well as ones that will come in the future. Like I said, initially we were looking at PEI, and so now we're looking at some of the options such as CalAIM, such as the marketplace, enhanced case management. So there are a lot of other opportunities that we think could be out there, but we do need time to be able to explore and to try to, find ways that are going to work. And I think the really integral part of this is CDEPs are community defined. They're community driven, and so there's a lot of variables with them. There's a lot of customization, a lot of individuality with it. And so they're not always as easy to just identify for all CDEPs to do one thing. We may have to look at some CDEPs may live in a prevention world. Not individual prevention. Some might be early intervention. Some might be able to utilize other funding. So that's what we're basically trying to do in response to the changes that we're seeing with the Behavioral Health Services Act. If we can go to the next slide, please. This does not change our initial learning question, which was really looking at how do you adapt, CDEPs community defined without having them lose what made them community defined in the first place, right? How do you make sure you don't make significant changes for the purposes of billing or purposes of alignment with funding requirements, and it loses what's community defined. So we're continuing that effort. We're adding now, like I said, a different sustainability component, exploring those, and also really looking at how we can leverage and utilize more data collection, data tracking, and utilization of the electronic health record. And that would be necessary for both billing, but also just to enhance and improve oversight. We did work on this with our 3 CDEPs in Fresno. This is something we've been working together since, I think, the listening session last fall with CDPH when they were exploring around 3 of CRDPs to try to do more CDEPs. So we've been working on this for a while. What's different with this extension refresh is that we're adding an additional partner to this project, which is Third Sector. Third Sector is one of the providers supporting counties and CBOs with enhanced case management, the DACS marketplace, and some of those other things. So they have that, and that's not going to be a cost. That's an area of expertise they bring. But specifically, Third Sector has on this particular project, Dr. Rhett, who has been, when it comes to the area of working on health disparities, health equity, The work that we've done has been around that area for years. Him and some others helped develop and update the Ethnic Services Managers Framework, best practices for cultural responsive services, et cetera. So we thought when we're talking about community-defined practices and really trying to find ways that we can both sustain them in terms of other funding sources, but also maintain the integrity of those programs, that this would be a great addition to the team to where they would have understanding and expertise in both areas. So if we can go to the next slide. And I am trying to fly through this for the sake of time as well. So, so as far as like the alignment, like I said, we're trying to look at the sustainability, and CDEPs are mentioned and referenced multiple times in the legislation related to BHSA, and was even referenced several times, today. The community defined practices are not always aligned with funding sources. A lot of them are prevention. They're oftentimes done by the very small CBOs that don't have capacity for billing. And so it's not an easy fix of saying, let's just do CDEPs, but we've got to figure out a way of how are you going to do them in a way that's sustainable. So that's really what we're looking at. How do we make sure that they are locally defined? How do we make sure that they're not population specific? And that's the thing I think sometimes the misnomer with CDEPs is people view them as population specific, and they're really community driven. So community driven with that population. So they're not always something that can be replicable throughout the state, the program, but ways to fund and sustain them could potentially be done. And that's really the work that we're hoping to do in these last 2 years with this project. These programs have been integral for our efforts to both reduce health disparities, but improve engagement with historically underserved and historically inappropriately or ineffectively served communities. And so for us, it's vital to not only find ways to sustain these CDEPs, but I think statewide and based on BHSA really wanting to see CDEPs more involved in the system of care and integrated into care, will really provide, this project will hopefully provide a roadmap for a lot of our counties throughout the state in doing this work. Last thing is, like I said, is just again, we're making sure that the adaptation does not make a program no longer community defined, doesn't lose that CDEP component of it. So we want to make sure that we continue doing this work as has been with the community, with the providers, and now we're just going to be adding an additional layer, which is really to assess, dive deep into the programs, look at all the work they're doing and see if there's ways that they can align either with new BHSA funding requirements or potentially utilizing Medi-Cal as a way for, or other funding as a way to be sustainable. And I think that we're going to go to, I think, second to last slide. Real quickly, the budget you'll see on there, the extension will cost about $2.9 million. I do want to call out the line items and the programs are kind of in that area with some increases based on annual increases, but evaluation component stayed. There's a new line item in there, which is the technical assistance provided by third sector. And if you'll see the department's admin costs, we've kept it down to less than 1% of the total project. So the money in this project is going almost fully to the understanding and exploration of the sustainability and doing the work with the community. And I think the next one is potentially my last slide. Yes. So the last slide, basically summation, our goal is to continue this effort, looking at ways that we can support these CDEPs because they are so critical and vital to the work. Looking at some of the new options that we can be done. And I know there's work potentially for a phase 3 of CDEPs done through the California Reducing Disparities Project, looking at some new populations and being a part of that work group for the past several months with several others that I think are on the call today. One of the challenges is again, that question of sustainability. That's great. We can look at new populations, new models. What about sustainability? And I think this project could support not existing CDEPs, planned CDEPs, but future CDEPs with providing not a roadmap that's going to work for every type of program, but it'll at least provide counties and provider and those CBOs with some ways that they can pursue that sustainability component. And with that, I am done with this presentation.
Thank you, Ahmad. We are now going to move on to the next innovation proposal. I'd like to invite Mendocino to present to us about the Native American Peer Crisis Line collaboration. We will hear from Rena Ford of Mendocino County and partners from the Pineville Pomo Nation. Rena, please go ahead.
Hi, good afternoon, Chair Madrigal-Weiss, members of the commission. My name is Rena Ford, and I thank you for the opportunity to present the Mendocino County Native American Warm Line, a community-created innovation project 3 years in the making. Next slide, please. Excellent. See, Mendocino County is home to 10 federally recognized tribes and 1 state recognized tribes, and many of our tribes are located in geographically isolated areas. Next slide, please. And for time, we're going to skip this one too. Thank you so much. And as you can see, Native Americans and Native Alaskans in Mendocino County represent 7% of the population of Mendocino County. But when we look at suicide prevention services, such as the North Bay Suicide Hotline, we see that only 4% of those who called the Mendocino County hotline identified as Native Americans. And you can see the graph on the left is the population, the proportion of Native Americans to everyone else in Mendocino County at 7%. And the utilization of suicide prevention is on the right with 4%. Next slide, please. The suicide rates in California are roughly 11 people for every 100,000 individuals. And like most rural counties in California, Mendocino County has a suicide rate of approximately 20 individuals per 100,000 individuals. Native American males in the state of California have a rate of 28.6 individuals per 100,000, making them approximately 3 times as likely to commit suicide. Next slide, please. Native Americans have faced a great deal of historic trauma, including, but not limited to, broken treaties with governments, forced relocations, boarding schools, and the destruction of culture through boarding schools, and even seemingly innocuous government structures such as the census have been utilized against our Native communities to find children and force them to go to boarding schools. Next slide, please. The ongoing barriers within isolated Native communities include high rates of drug and alcohol use, low school attendance, a general disconnect between tribal communities and the knowledge of available services, often caused by changing programs and a lack of continuity with changing funding sources, such as grants and various government prioritizations. Native communities also have to contend with a high rate of murdered and missing Indigenous peoples, as well as the isolation of rural communities and the lack of mental health services available in small communities. Indeed, some communities in Mendocino County do not have ready access to stable internet services, further reducing the availability of services as even telehealth is unavailable. Next slide, please. Now, in all communities, stigma around mental health services is high, but in Native communities, we've learned from our previous innovation project that nobody wishes to receive mental health services if we are calling them mental health services, but they are willing to receive services as long as we're calling them something else. Individuals would love to come and receive services such as a shower or hot food or even help with paperwork. And this stigma continues to be high in many demographics. Next slide, please. For Native Americans living in isolated regions, there are other reasons to not engage in crisis services. For instance, transportation issues are a large concern when the nearest hospital is 45 minutes away by car. Not everyone drives or has access to a car or the money for gas for a car. This removal from their homes creates a financial burden on families who now have to travel to support their loved one who is in crisis. With limited access to transportation, sometimes the bus is the only option for families to go to and from hospitals. And with little service to our outlying areas, these trips are limited and rigidly scheduled. Sometimes the person who is seeking services is the only responsible adult in the house, and being detained for crisis would also create situations involving CPS or other government agencies, further complicating recovery. And after all of this, if a person is transported to the nearest hospital and not placed under a hold, they are then released at the hospital, often with no transportation back to their community. These are scenarios that we have witnessed in our communities, and while these considerations are increasingly weighed in our crisis situations, historically, these items haven't been given the necessary consideration. The living memory of instances that were not handled delicately furthers Native American distrust in government-run programs. Next slide, please. Now, we have a number of various warm lines and hotlines throughout the state. We have 988, a hotline. We have the county-run crisis line and the California Red Line. Now, the California Red Line is a Native-specific crisis line, but it is not Mendocino County specific. And we also have the domestic crisis lines in Project Sanctuary and the Strong Hearts Native Helpline, which again is focused on Native Americans, but not specific to Mendocino County. Additionally, we in Mendocino County have a warm line and an access line specific to Mendocino County, but it is not specific to reaching Native Americans and is run by the government, a known untrusted resource. Next slide, please. As part of our innovation project, we hope to learn why Native Americans do not seek help. We also wish to learn how can mental health services provide more of the needed services, and what are the barriers to Native Americans seeking help today. Next slide, please. Our hoped for learning goal outcomes include a tip sheet. This tip sheet will be designed to help create continuity for the program staff, as staff turnover is common in many service positions, and Native American positions are not immune to this. The tip sheet will also be available for providers within the mental health system to give to their Native American clients and to help providers understand their clients' needs. Second, because the Warm Line is a low barrier service, it will be a place where people can call to talk to other people with similar lived experiences. Ideally, the Warm Line would not only be used for triage and referral services, but also for providing information and continuity as a network. Third, with the Warm Line staffed by people with lived experience, the hope is that this lived experience will increase the likelihood of those calling the line to receive relevant services and be able to help troubleshoot current barriers to services in a way people outside of the Native community would not be able to do. Due to the close-knit nature of our tribes, there is a significant crossover between Mendocino, Lake, and Sonoma County tribes, and we hope our project will be able to expand to service those regions as well. Next slide, please. The Native American Warm Line will align with BHSA by preventing substance use and mental illness disorders from becoming severe and disabling, by having up-to-date service information, referral, and triage services, and provide peer-to-peer services for an at-risk, underserved population. Next slide, please. The budgeted items in the innovation project are as follows: a lead warm coordinator, a warm line coordinator, trainees. There are various operating costs such as IT services, utility vehicle costs, and office supplies. This project also calls for computer purchases, laptops, office and desk and chair, and the county is also budgeted for administration fees. Next slide, please. As you can see here, this is a summary of our whole budget. Our largest expenditures are personnel, then direct costs, and then other expenditures, largely with the startup of the project. Next slide, please. The sustainability for this project is likely through BHSA services, as mentioned previously, as the services provided do align with BHSA, specifically the BHSS portion, and especially with the peer-to-peer service delivery model. Additionally, grant funding will be more feasible should this project be a success, as grants don't often wish to fund untested projects. And should the training portion be successful, the peer advocacy through mobile crisis might be another area where we can successfully sustain this project in the future. And I believe this is my last slide. Next slide. I would like to thank everybody for your attention today. Myself and my Native partners are happy to answer any questions you may have. Thank you.
Thank you, Rena. And we will get to our questions once we hear from our last presenter. So thank you so much. We will now hear from the innovation proposal on psychiatric advanced directives, or PADS. We have a request from both Shasta and Fresno County to utilize innovation dollars for phase 2 of the PADS project. I would like to invite Karen Sahota to start us off on the PADS innovation conversation.
Thank you, and good afternoon, Chair and members of the Commission. Again, my name is Karen Sahota. I am the contractor with Concepts Forward Consulting. That is the project director for the multi-county project. And I can't see the slide, so I'm just going to say next slide. There we go. Thank you. And so because of time, I'm going to make sure that I'm not going to read all of this. So really just looking at that, if we can go to the next slide, I can really showcase some of the aspects. Really, in order to do phase 2, we have to look at what happened in phase 1. And the amazing accomplishments of this collaboration has been phenomenal. And so being able to look at the creation now of a standardized categories, our project was able to look at psychiatric advance directives throughout the United States and identify specific digital categories that were then built into a digital web-based platform. And so that's Richard, and being able to identify an individual when they're not in crisis. Our project also looked at creating a logo, something that was really recognizable. And this is utilizing the voice of our peer community, our families, our first responders, as well as additional stakeholders, as well as, of course, our county participants. Next slide. So really what we look at within phase 2 is the fact that California is the 5th largest economy in the world, and we lead in the digital space. So you look at Apple, Microsoft, Tesla, even ChatGPT is here in California. But we also lead the nation in our unhoused communities, substance use disorders, and we spend $1.5 trillion annually on adverse childhood experiences. And so really looking at technology that is guided, humanizing, and recovery-based, as well as transformative. We also look at in phase 2 is that training needs to go beyond one and done, boots on the ground and engagement. You cannot create change without a mindful rollout, understanding it takes time to truly change a pattern of thinking and action. And so looking at the fact that the counties do have often throughout the whole state right now, as we know, the workforce shortage is, so phase 2 is really doing more of the hands-on to help the counties really roll out that innovation and engagement to be able to look at the use and access of the digital pad, to really look at legislative efforts that uplift the access and importance of directives. And phase 2 will truly test the validity of decreasing recidivism of unnecessary hospitalizations, incarcerations, 5150 applications, to truly engage in advocating for directives and preference for treatment using an individual's own voice. Next slide, please. So then we look at how does this project and PADS fit into both the MHSOAC or the BHSOAC and Prop 1. And really, it aligns beautifully. If you really look at PADS and understanding that a psychiatric advance directive can follow an individual throughout their lifespan, we really are looking at, even within the MHSOAC strategic planning, is the advocacy for system improvement, for supporting that universal access to mental health services, a participation in change in statutes, and of course, promoting access across the continuum. Under Proposition 1, and even with listening to the full service partnership conversation today, again, psychiatric advance directives, what a beautiful fit. And looking at our unhoused individuals with housing and supportive housing services, early psychosis, again, individuals that are having maybe their first break, but are not necessarily looking at end-of-life decisions, but are looking at decisions and preferences that they can determine that will follow them throughout their life, and how they can make those adjustments based on their life changes. And of course, also with mobile crisis and the rollout of SB 43. Next slide. And though I don't need to go into how PADS fit into all of these categories, you can absolutely see how PADS fit seamlessly into our justice involved, our wellness centers, what a wonderful area as well. And most importantly, that digital PADS just fit across the continuum of care. And as I mentioned earlier, that being able to follow through the lifespan, as well as I love the comment earlier today, is to end the churn for many of the individuals and really look at that recovery base outcome with a psychiatric advance directive. Next slide. Is that of sustainability. And when we look at sustainability, we are looking at the reduction of the recidivism of jails and hospitals, which equals that increased county funding. When we look at peer facilitators that can bill Medi-Cal, we look at increased workforce funding. Increased workforce, when you can hire peer support specialists, certified peer support specialists, to actually be able to facilitate a PAD. to look at the partnerships and collaboration to identify the appropriate resources, to really look at that investment in recovery, and additional legislation as we look at sustainability going forward, because PADS are not just a few counties. As you can see about the collaboration, PADS touch on everybody in our state, and really looking at how this can become a statewide initiative to really increase the use of PADS access and use in the state of California. And really, and the last one is the future behavioral health care and policing by utilizing the directives. And by utilizing those directives, we really look at that sustainability as well. And with that, I'd like to pass it over to my colleague from Fresno, Ahmad.
Thank you, Karen. This will be really quick. As far as our involvement with the project, Fresno was actually, if I recall, the first county that joined the initial PADS project sponsored by the OAC pre-pandemic. So we've had some investment and some involvement in this, but from an empowerment standpoint, if you go back and look at our documentation, and our initial impetus for this project was to look at it being an empowerment tool. It was not necessarily compliance, but really empowerment, looking at it as a way that fosters more supportive decision-making. People have a more control of their own wellness, but also hopefully that increases their engagement, knowing that they are the authority on themselves and they will have some control over their care. Our stakeholder expectations, we've been involved with this project, like I said, since its beginning. Not only do we have the financial investment and time investment, but our stakeholders have been involved in the various phases of this, and they're really interested and excited to see its implementation and actually see it come to fruition. So we have expectation from our stakeholders on several levels. Investment, I think after Orange, we were the second largest investor in this project, investing close to $2 million in this. So for us, it just makes sense for us to continue. It doesn't make sense to invest the money and then walk away from something, even though it'll eventually benefit the state and everyone in there. For our investment, we want to make sure that we get some opportunities to make sure that we can test it out and make tweaks and make sure that it works for some of the populations and that we're looking at doing. And just in case there's not a lot of counties that opt into, participate in their second phase, it's really critical to have at least some counties with experience continuing this work. So that was kind of our investment. Future impacts, I don't need to touch that. Karen provided multiple examples of that, from AOT, changes to conservatorship and LPS, CARE Act. So I think there's a lot of opportunities there, and remembering that PADS is not limited to just those individuals who access behavioral services in the public system, but it is something that is a resource and a tool of empowerment for families and individuals throughout the state. So it reaches a lot of levels, and hopefully by having that tool and resource, we can also limit the amount of impact individuals may have on things that are jointly. So like a ED department, which is not just, run by, it doesn't individuals we serve, but the community as a whole. And last, I think it's really important to think about the sustainability, and why we think this is really vital is doing this next phase allows us to actually take the technology, take the project, and actually put it into use and make sure that it's working, it's accessible, it's working the way we have intended to, and it's having the outcomes we have. And then I think you look at, for lack of a better term, like the true sustainability. So I think there's some steps that we're hoping to get done in this phase that will actually then fuel and support sustainability, versus just looking at, well, we're going to fund this for the next 10 years without actually knowing, is it giving us the outcomes we want? So a lot of data, a lot of evaluation, a lot of, and I'm sure Karen can answer those, partnerships with first responders, different, sectors to really test this out and get it to where we need it to be statewide. So that's Fresno's part as far as with this phase 2.
And next would be Shasta.
Hi, and thanks for having me. My name is Ashley Seychow. I'm newer to the MHSA world, but jumped on as soon as we got this project presented to myself. But I wanted to share Shasta's voice as a small county. It does allow for the opportunity for informed decision-making, and our stakeholder expectations is that this project does move forward, and it provides an additional tool for professionals, families, and those that experience mental health issues. The investment is the time commitment that Shasta has committed to this project, and the time commitment of our peers. This is a heavily peer-driven project from every aspect of building this project, and our peers here in Shasta County are fully invested, from Bernie, California to Redding. We try to include everyone in our rural areas and our small city of Reading. Future impacts, we would help reduce, with this project, it would help reduce escalated interactions with professionals and improves the overall system of care. In terms of sustainability, it invests in peer support specialist programs. And once this becomes a statewide program, then it actually would help implement and actually potentially grow all peer support specialist programs within all the counties across the state of California. And the fact that this does coincide with being able to be Medi-Cal billable definitely helps in increasing fundings to our county departments. The testing and the evaluation phase will definitely prove that this is an effective tool. And like Prop 1, we're bringing an outdated item into the future to align with our modern times. Next slide. And I just wanted to share a couple of voices from our local peers here in Shasta County. And next slide. Thank you.
All right, thank you so much. We want to thank all our presenters for these proposals. At this time, I would like to invite commissioners to offer brief comments or ask questions about any of the innovation proposals presented today. This time, I don't see any questions or comments regarding these. I do have one question. Just one. I want to thank all counties here. I have a question for Mendocino. And I didn't hear this, but I'm curious. The age of use for the warm line.
Yes. Rena Ford, Mendocino County. The age of use for the warm line is anyone who would like to call. It's anyone who can call it. It's the same for instance, the North Bay Suicide Hotline.
Excellent. Thank you so much. And I saw the lower rates of school attendance, and I'm just bringing this up. I recently went to the American Suicidology Conference, and I learned this for the first time. New research came out last year that is associating chronic absenteeism with a 20% increase in suicidal ideation. So we are really looking to our schools around engagement and absenteeism. So big concern there. So thank you for lifting up all that data. I just wanted to make mention of that. So I am seeing no question. I am seeing Vice Chair Alvarez, please, has a question.
Thank you so much, Chair Madrigal-Weiss. I'm not sure if it's a question or more sort of a comment. I want to appreciate the perspective of each of the counties on the proposals and how they'll be impacted by Prop 1, and just sort of putting forward some of their analysis and expectations or wonderings about what's to come. Obviously, there's a lot of questions with the unknown, but want to highlight that in connection to the previous conversation we had around full service partnerships and past conversations we've had around Prop 1 implementation, and just really giving credit to the staff and the commission as a whole in standing as a partner to the department around implementation. I think these types of programs that support county-specific needs, population-specific needs, like what's going to happen to these types of programs as Prop 1 moves forward, and being good stewards of the resources while being responsive to our community's needs. There's just so much more to learn. And I'm just really, I want to extend my gratitude for the counties as good partners, and as well as this team for really putting in the work to think through that together. And I look forward to us being good partners to the department as we assess implementation. Like we heard in the past, Stephanie Welch talk about how can we be good partners. Like this is part of that work. And I just want to really highlight some of that analysis that we saw in these presentations, and how we'll be using that moving forward, and just extend, deep appreciation for these great ideas and how we can be more responsive to community needs.
Thank you, Vice Chair Alvarez. Excellent point. At this time, we are going to move on to members of the public. They may request to make a public comment on agenda item 7 by clicking the raise hand button on your computer or the app, or if calling in by phone, pushing *9. I am going to request that public comment be shortened to 2 minutes, just because, again, we do not want to lose quorum. So are there any public comments? Amariani, please raise your hand now as the queue will be closing.
We currently have 2 public comments. The first one is from Stacy. Stacy, your line is open.
Good afternoon, Commissioners. Stacy Haramoto with REMCO, the Racial and Ethnic Mental Health Disparities, and also representing today some of the community partners of the California Reducing Disparities Project. We would like to support the Fresno County Innovation Proposal that Ahmad Barami presented so well. We urge the Commission to approve the funding for this Fresno County project that would allow the community-defined practices that have solid research evidence behind them to continue. As Ahmad pointed out, it is important that CDEPs do not have to change the way they operate in ways that alter the program so it is no longer culturally congruent. Although there are new opportunities for CDEPs, not everyone recognizes this, and they try to get organizations to become Medi-Cal eligible when this is not beneficial for the program, or to change eligibility requirements for the community members that are not conducive or culturally competent. The CRDP looks at Fresno County as both the champion and leader in how counties can support CDEPs. We know that partners in other parts of the state will use Fresno as an example to advocate these support strategies in their own counties, and that Fresno County will be more than willing to share the information they learn from this innovation project. Please support Fresno County's proposal. Thank you.
Thank you, Stacy.
Our next public comment is from Marie. Your line is open.
Hi, good afternoon. My name is Marie Marks, and I supervise a team of peer support specialists here in Shasta County. One of my peer support specialists, John Bergen, actually wrote in his thoughts that he wanted me to share because he wasn't able to attend the meeting. So I'll go ahead and read that. Sorry I'm not able to attend, but I do want to express how important a PAD would be for myself and all the individuals that I support as a certified Medi-Cal peer support specialist. I truly value the idea of having an instrument that can speak on my behalf if I find myself in a situation where I am unable to advocate for myself due to a mental health crisis or devastating incident. I am an individual that lives with PTSD from bodily blunt force trauma, ADHD, and have lived with substance use disorder and self-medication for much of my life. I have been an incarcerated individual for making poor choices while in crisis and can see the value of having a PAD in place. I have never been hospitalized due to a mental health crisis yet, and I hope that that never happens, but I do not know what the future holds for me. If something very unforeseen were to happen in my life, I do not think that I would handle it very well and may even move into crisis. But if that were to ever happen, it would be very reassuring that I have a personal instrument in place that can advocate for me, my safety, and my wellness. A psychiatric advance directive, my plan, my voice. Sincerely, John Bergen, certified Medi-Cal peer support specialist.
Thank you, Marie.
That was our last comment.
Thank you, Amariani. So we are going to be asking for a vote per county. So at this time, I would entertain a motion that we approve Ventura County's Early Psychosis Learning Healthcare Network Collaborative Innovation Project.
Madam Chair, I'd like to make that motion.
Thank you, Commissioner Rolette. We have a motion. Do we have a second? Second. Thank you, Commissioner Budge. Are there any questions or comments from commissioners regarding this? Seeing none in the room, seeing none online, I would ask then that, Sandra, you please take the vote.
Bontrager. Brown.
Aye.
Bunch. Aye. Carnevale.
Aye.
Carrillo. Chambers.
Ventura.
Okay. Cortese. Danovich. Gordon.
Aye.
Mitchell. Robinson. Rolette.
Aye.
Alvarez. Madrigal Weiss.
Aye.
Yes, I'm going to go back and say Danovich. The motion passes.
Thank you. Congratulations, Ventura County. We are now moving on to Fresno County's extension of the California Reducing Disparities Innovation Project.
Move approval.
Commissioner Gordon, we have move approval. Do I have a second?
Second.
Commissioner Rolette, we have a second. We have a motion and a second. Questions or comments? Seeing none, I'm going to ask Sandra that you please take the vote.
Bontrager, Brown. Bunch. Carnivale.
Aye.
Carrillo. Chambers. Cortese. Danovich. Gordon.
Aye.
Mitchell. Robinson. Roulette.
Aye.
Alvarez.
Aye.
Madrigal Weiss.
Aye.
The motion passes.
Congratulations. I am now asking that we entertain a motion that the commission approve Mendocino County. I would like to move the motion, and can I have a second? Second. Thank you, Commissioner Brown. We have a motion and a second. Questions, comments? Seeing none, I would ask then, Sandra, that you please take the vote.
Bontrager, Brown. Bunch. Aye. Carnivale.
Aye.
Carrillo. Chambers. Cortese. Danovich. Gordon.
Aye.
Mitchell. Robinson. Roulette. Alvarez.
Aye.
Madrigal Weiss.
Aye.
The motion passes.
Excellent. Congratulations, Mendocino County. And we are moving on to approve Fresno County's participation in the Psychiatric Advance Directive Collaborative.
Move approval.
Thank you. Commissioner Gordon, do we have a second?
Second.
Commissioner Carnivale seconds. I don't see any questions or comments. I would ask Sandra then that you please take the vote.
Bontrager, Brown. Bunch. Carnivale.
Aye.
Carrillo. Chambers. Cortese. Danovich. Gordon.
Aye.
Mitchell. Robinson. Roulette.
A little bit
Alvarez.
like there was a Aye. form.
Madrigal Weiss.
Aye.
The motion passes.
Congratulations. We are now moving on to Shasta County's participation in the Psychiatric Advance Directive. I would ask for a motion. Commissioner Rolette, and a second.
Second.
Thank you, Commissioner Gordon. No questions, no comments. I would ask then, Sandra, please take the vote.
Bontrager. Brown. Bunch. Carnivale.
Aye.
Carrillo. Chambers. Cortese. Danovich. Gordon.
Aye.
Mitchell. Robinson. Roulette. Alvarez.
Aye.
Madrigal Weiss.
Aye.
Motion passes.
Excellent. Thank you. Congratulations to all the counties. Motions passed. All right. Record time. Thank you. We made quorum. Appreciate you all, commissioners. Thank you for that. And thank you, Sandra. Whip through those names. All right. Next on, we will move to agenda item 8, the May revised budget update. The commission will hear an update on the state budget and the governor's May revised budget proposal. I would like to welcome Norma Pate, Deputy Director of Administrative Services and Performance Management, to come up and present. That is a long title. We should get an acronym for that one. Welcome, Norma.
All right, thank you, Commissioners and Chair, for being here today and for your time. In your packets, there's a couple of things to help y'all make this presentation fairly quick. We don't have a ask today for any type of approval, but in your packet is the agenda item that lays out some of the information that was in the governor's May revision that as it relates to behavioral health and a PowerPoint. And then there was also the printer wasn't cooperating with me this morning, so this is a fairly large document, but it's a document that looks similar to this, that is a side-by-side that shows you what was included in the January budget related to behavioral health, and then the May revisions. And if there's questions you have after this presentation that I didn't answer for you today and you'd like me to research, please let me know, and I'll be happy to work with the budget committees to provide more information. Okay, let's see. Today, just wanted to highlight, some of you may have already heard that in the May revision, the governor estimated that the fiscal deficit for the 2024-25 fiscal year grew approximately $7 billion from the January proposal to approximately $44.9 billion. The remaining budget problem is estimated at $27.6 billion after accounting for the early action budget package that included $17.3 billion in solutions. Oops. I don't think this is oh, there we go. Okay. Sorry, my clicker wasn't working. The May revisions to the governor's proposed budget include several significant changes and updates related to the behavioral health services. A reduction of $854.6 million will be made to healthcare workforce initiatives over the next several years. The May revision also eliminates the $184.4 million mental health services fund for programs proposed to be delayed until 25-26. Children and youth behavioral health initiative reductions include $72.3 million eliminated in 2023-24 and $354.6 million in the following years for school-linked health partnerships and capacity grants for higher education institutions, behavioral health services and support platforms, evidence-based and community-defined grants, public education and change campaign, and youth suicide reporting and crisis response pilot. These reductions will not have impact on the grants the commission is working on in collaboration with DHCS. The reduction for the evidence-based and community-defined grants will be for round 6 that have not been awarded yet. We hope to learn more over the next few months and will continue to communicate our findings to you. Also, the Behavioral Health Continuing Infrastructure Program will be reduced by $450.7 million one-time funds from the previous round, while the general fund will remain at $30 million one-time in 2024-25. And then Bridge Housing Program will be reduced by $340 million over multiple years, while maintaining $132.5 million general fund in 2024-25, and $117.5 million, of which $90 million was in Mental Health Services Act funds, and $227.5 million general funds in 25-26. Oops, I'm going backwards, I'm sorry. And the proposed revisions to the commission's budget include 3 additional positions to support Proposition 1 changes to the commission. The 3 newly created positions are necessary to accommodate the additional workload associated with the implementation of Prop 1. To facilitate the name change from Mental Health Services Oversight and Accountability Commission to the Behavioral Health Services Oversight and Accountability Commission, $100,000 per year over the next 3 years is available to support us with that process. And then the Mental Health Student Services Act funds will be transferred to the Mental Health Services Fund, reducing the commission's budget by $7.6 million. As a result, our current competitive bidding process will not be affected, and we will continue to award funds from the fiscal year 2024 onward. We will continue to prioritize mental health services for our students, and we are committed to ensuring that the funds are allocated in the most effective way as possible. And that is all I have today, and I will provide you with another update on the commission's budget after it's been passed and signed by the governor in July. Thank you for your support and happy to answer any questions.
Please, Commissioner Chambers.
And sorry if I didn't do my good homework. Can you say the positions or tell me what positions that you guys were going to hire for?
The 3 positions, it is, there's a health program specialist 2 position and an AGPA position for our program side, which is associate government program analyst, sorry. And then we also have an associate government program analyst to help with legislation and legal.
And maybe this hasn't been worked out, but which of those staff will be like coordinating with all the new appointments at some point?
The new commissioners,
Yeah. Is it in that profile or no? Not yet?
most likely that will be something that we'll absorb internally. We're putting together an onboarding process for new commissioners. And so I'm working with Kendra on that process, and we may use our new associate government program analyst to help us with that process.
Awesome. Thank you.
You're welcome.
Vice Chair Alvarez, please.
Thank you, and thanks, Norma, for the overview. I want to first and foremost say how it's a difficult budget year for our state of California, and there's always difficult decisions to make, knowing that the economic climate is not where we want it to be and not where it's been in years past. At the same time, the decisions we put into a budget are our choices, and they outline our values. And I want to just express my own disappointment in some of these cuts, in particular the cuts to the Children and Youth Behavioral Health Initiative. That was an incredible opportunity that the state of California put forward to really take a stand on the youth mental health crisis that existed before the pandemic and that was exacerbated as a result of it. And I wanted to highlight, just how connected that work is to the longstanding work of the commission on student health, on youth health, on TAY, on a number of different commitments to ensuring our youngest people are the healthiest they can be, and wanted to see if there's an opportunity to express our concerns with those reductions, given the commission's partnership role in implementing CWA. More importantly, again, this longer term commitment in being a good partner to the administration and bringing the expertise of this commission into the collective work we have to make California a better state for promoting the mental health of all who call it home. And I don't know what that process looks like. Again, I want to recognize that it's not just expressing disappointment with the cuts, but also offering our partnership as we move forward and thinking through how we together together with stakeholders and community organizations and the legislature and a number of different partners, try to ensure that we're doing everything possible to address this crisis and ensure that our commitment remains as strong as ever.
Thank you.
Thank you, Vice Chair Alvarez. Commissioner Gordon.
Yeah, I'd just like to, in a way, reiterate the comment that I made earlier, that even separate from these cuts, I think there still is a huge opportunity to join with First Fives around the state and to push the notion of delivering much more preventive services and really honing in on the managed care, the existing systems delivering much more of the preventive services. Because I think that some of the work that we've been doing by putting some clinicians in schools is, a lot of it is designed to reach down and help reach down into the elementary grades and from there into the preschools and the child care programs with family navigators and other personnel to really focus the coverage that's there already for our families on these preventive services. So I think there are still many opportunities to push that, and some of these funds would have been directed also at higher education, and which is being paused for a while. But again, I think the real progress long term is in prevention, early intervention, and making sure that we stem this pipeline of severe issues down the road in elementary schools, middle schools, and high schools. Thank you.
Thank you, Commissioner Gordon. Commissioner Carnevale?
Thank you, Madam Chair. I'm not sure it's worth spending the time to say this because this is above our pay grade, but I just want to point out, first of all, the economy is actually recovered already. It's doing very well by all measures, even though the public sentiment doesn't always reflect that. This budget deficit is a result of what happened last year. There's every reason to believe it should be better going forward. And it's just ridiculous that the state has a one-year budget process. No normal organization runs an organization this way. At home, we don't say, well, our paycheck is low this month, so we're not going to feed our kids. I mean, you make arrangements for this. So I just think this whole exercise is ridiculous.
Thank you, Commissioner Carnevale. Commissioner Mitchell, please.
So to kind of piggyback on that, I am curious. So if next fiscal year, because some of these cuts are like this year, the Children and Youth Behavioral Health Initiative over the next 3 years. So what if things turn around? Does this get adjusted, Norma?
It can be, yes.
Okay.
Yeah. There's adjustments to prior year budgets right now, and so they can also make adjustments, going forward next year if the economy increases.
Thank you.
One thing I did forget to mention in the beginning is there's also a proposal to reduce positions within the state, permanent positions within the state by 10,000. And we haven't received any direction from finance or the governor's office on any reductions to the commission, and we're not anticipating any reductions to our current positions. In prior years, when they're reduced positions, they would go after vacant positions first or limited term positions, and then it would be based on a percentage. And so we haven't gotten those instructions or those directions, so I'll continue to monitor that and make sure that I keep everyone updated on any changes.
Thank you, Norma. I think it's important, all the statements that my fellow commissioners have made are valid, and I agree with all of them. And still, I think we need to stay actively involved. And really, Commissioner Vice Chair Alvarez, the CYBHI represents a historic investment in prevention and early intervention, which we know would result in long-term cost savings in the end. I'm also concerned about the proposed budget cuts affecting children and families, particularly those that increase culturally relevant and linguistically appropriate behavioral health services aimed at addressing health disparities. We've worked so hard for that. We should all stay actively involved in these budget discussions. Vice Chair Alvarez, I would ask that you guide our staff in this process and prioritize protecting our children and youth, especially those from our most marginalized communities. I know when we have a staff member working alongside with staff, we stay on top of this. So I would invite you, Vice Chair Alvarez, to work with staff and keep us posted on this so that it really does stay in the forefront of the Commission's work going forward and conversations. Could I invite you to do that?
Absolutely, I'd be honored to. And however I can be helpful in collecting input from fellow commissioners with the help of staff and ensuring we are getting that important perspective, and then of course circling back. Absolutely, I'd be honored.
Thank you, Vice Chair Alvarez. And for anybody who wants to participate with that, please just let us know, and we will make sure that we're watching. We are watching. We are always watching. Thank you, Vice Chair Alvarez. Very much appreciate your leadership on that. At this time, members of the public may request to make public comment on agenda item 8 by clicking the raised hand button on your computer or the app, or if calling in by pushing *9. Are there any public comments? Amariani, please raise your hand now as the queue will be closing.
We have 2 hands raised. Okay. The first public comment is from Stacy. Your line is open.
Thank you. Stacy Hiramoto again with REMCO, the Racial and Ethnic Mental Health Disparities Coalition. And I really want to thank Commissioner Alvarez for bringing up the cuts to the CYBHI. REMCO and the CRDP were very concerned, particularly because the cuts that are being made will actually affect, in our opinion, communities of color and the LGBTQ communities more. Sadly, you know, it's one of those last hired, first fired. Well, you know, programs that serve BIPOC and LGBTQ communities, it's like last funded, first cut. And one of the programs being cut is strictly for CDEPs. And we know, you all know that we've told you how those help our communities. But I did want to tell you something else. I don't know, I know some of you have worked a lot with the legislature, but I really want to commend the OAC staff because I know how hard they've been working. Your executive director and also Norma and Kendra, I actually see them at the hearings. And on, you know, the May revise came out on Friday, right, the 10th. And then, you know, the very next week, we had to be prepared and testify and wait and wait and wait and hear what, you know, the hearings are arduous. And then after those hearings last week, they did another analysis that was put out on Sunday. And then you had to be ready to testify at both budget subcommittee hearings at the Senate and Assembly side on Monday. And I've seen your staff there. On Monday, I did not get home until, you know, like 11:30 p.m. So I know, I just want you to know how hard your staff works too. So thank you.
Bravo. Thank you, Stacy.
The next comment we have is from Jasmine. Your line is open.
Hello, everyone. Good afternoon, commissioners. My name is Jasmine Esteves Rosas, and I'm a policy associate with the Children's Partnership. We're a statewide children's health equity organization. The Children's Partnership and many other children, youth, and health equity advocates have significant concerns regarding proposed cuts to the Children and Youth Behavioral Health Initiative in the governor's May revision budget proposal. These proposed cuts, particularly to the evidence-based and community-defined practices grants and the youth crisis response pilot, could disproportionately affect youth of color and hinder access to culturally responsive healing services. Additionally, cuts to infant and early childhood mental health investments are concerning, given the critical impact of preventative services on future mental health outcomes. Despite previous investments, these issues persist in providing mental health services to low-income children and youth. And rejecting these cuts is crucial to maintaining progress in addressing the mental health crisis among marginalized youth and ensuring equitable access to necessary care and support. We urge the Commission to communicate to the legislature the necessity of maintaining these CYBHI investments as essential to building a comprehensive mental health ecosystem of care for California's kids. Thank you for considering.
Thank you, Jasmine.
That was our last public comment.
Thank you. Norma, again, thank you for sharing that with us at this time. We are going to move on to agenda item 9. We will be focusing on the implementation of the Commission's strategic plan. I am, however, going to ask that we take a 15-minute stretch break. We had a working lunch. We needed to get through all the voting items with quorum. I think I'm looking around the room and our commissioners need a 15-minute stretch break. We are going to take that now. So we will be back in 15 minutes. It is 2:03. We will be back at 2:18. Thank you, everyone, for your understanding. All right. Welcome, everyone. We are back. Commissioners, in front of you, there should be a copy of a document that says Strategic Plan Implementation Questions. So, and there should also be a handout that's a brochure, thank you, that says Accelerating Transformational Change. So you should have a copy of the strategic plan implementation questions. It looks like this, and a brochure that looks like this. So please find those as Norma begins her facilitation of this conversation for us. So Norma Pate, I hand it over to you.
All right, thank you, Chair. All right. Okay, in January, the Commission adopted a strategic plan for 2024-27 and directed staff to develop a mechanism for tracking and reporting progress against its strategic goals. As part of the process of achieving the strategic plan's goals and objectives, specific metrics and tasks were identified. As part of our effort, we have also developed an appendix that describes how we will proceed in more detail to achieve our goals. And we plan to provide the Commission with a scorecard each month in your packet that shows the status of our goals and objectives. Oops, I did it again, Cody. Sorry, we have a new clicker and I'm not used to it. Today's presentation provides the Commission and the public with draft metrics, including aspirational metrics in support of the Commission's goals. These metrics are intended to be used as a framework for the Commission's ongoing evaluation of progress towards its goals. They will provide the Commission with guidance and direction as it works to achieve its goals. As Commissioner or Vice Chair Alvarez and Commissioner Chambers mentioned earlier, that I presented to the CFLC and CLCC Joint Committee, and we got a lot of good feedback from the committee around our strategic plan. And I'm not finding my slide, I'm sorry here. Okay, I think we have the wrong version, but that's okay. We received feedback from our CFLC and CLCC committee on some additional metrics that they would like to see in our plan. And so we'll be discussing those and hopefully incorporating those into our strategic plan as we begin to implement the plan. The Commission's strategic plan consists of 4 key foundational actions, and our first goal is champion vision into action. This goal will be achieved by analyzing data and engaging with community partners. This will enable us to develop policies that provide early, effective, and universal access to behavioral health support and services. Community partners play a crucial role in developing effective policies by providing valuable insights and diverse perspectives. Their input helps ensure that the policies address the specific needs of the community and culturally sensitive. In collaboration with community partners, the Commission can tap into their expertise and collective wisdom to design and implement initiatives that have a higher chance of success and meaningful impact. The first objective is to elevate the perspective of diverse communities. This objective aims to measure public trust in behavioral health programs across diverse communities. One potential challenge in measuring public trust in behavioral health programs is the subjective nature of trust itself. Trust is a complex and multifaceted concept that can be influenced by various factors, such as personal experience, cultural beliefs, societal perceptions. And additionally, measuring trust requires reliable and valid assessment tools that accurately capture individuals' perceptions and feelings towards behavioral health programs. This task can be particularly challenging when it comes to developing culturally sensitive and appropriate tools for diverse communities. But as you can see here, that is our aspirational goal. Secondly is the assessment and advocate for system improvements. We also aim to evaluate and advocate for improvements in the behavioral health system as part of our second objective. During the next few years, the Commission will make significant progress in developing and implementing all the policy projects we have at the moment. And the third is connecting federally and globally to learn and apply is the third objective. By publishing articles, white papers, and policy briefs, the Commission will be able to provide insight into best practices and trends at the state, federal, and global levels. The Commission will also engage in conference presentation and engage with community partners media coverage, and legislation. And goal 2 is to catalyze best practice networks. The second goal is to catalyze best practice networks to ensure access, improve outcomes, and reduce disparities to close the gap between what can be done and what is being done. Through its work, the Commission will engage public and private stakeholders, including universities and institutes, to create best practice networks of excellence. And then supporting organizational capacity building. To accomplish this, the first objective, the Commission will provide support for capacity building initiatives and progress reports on best practice networks. We aim to establish a repository of best practice research, evidence toolkits, and related materials. And objective 2, fortify professional development programs and resilient workforce strategies. As part of the second objective, professional development programs and resilient workforce strategies will be strengthened by participating in the Transformational Change Partnership, engaging with workforce funders, and investing in the behavioral health workforce in California with the goal of inclusion and diversity in the workforce. Develop adequate and reliable funding models as a third objective. We aim to develop reliable and adequate funding models either by securing funding for best practice networks or by linking outcomes and funding. Supporting system-level analysis to ensure the tailored care and universal access required to reduce disparities as a fourth object. We aim to support system-level analysis to provide tailored care and universal access necessary for the reduction of disparities through Commission-led policy research and Commission-supported policy research, as well as an expansion of external analysis supporting tailored care and universal access to decrease disparities. And inspire innovation learnings. The Commission's third goal is to inspire innovation and learning to close the gap between what can be done and what must be done. To improve behavioral health and well-being, the Commission will develop strategies and partnerships to catalyze innovation and accelerate the development and dissemination of new models and practices that further improve behavioral health and well-being. And the next objective is the first objective is to prepare an analytical narrative regarding the potential for innovation in order to improve behavioral health outcomes. Learning from the innovation engagements of public sector innovation, best practices resulting from innovation, and public awareness of innovation will be disseminated. Next, we have establishing an innovation fund. Public and private investments are linked and leveraged, securing funding and investments made, and ensuring a return on investment. And objective 3 is to accelerate the learning and adaptation of process in public policies and programs. We can achieve this objective by engaging in public sector innovation, best practices from innovation, and public awareness and interest in innovation. And the fourth goal is to relentlessly drive expectations in ways that reduce stigma, build empathy, and empower the public to drive accountability for outcomes. To improve the public behavioral health system, the Commission will work with all Californians to strengthen public understanding, empathy, trust, and empowerment. To reduce stigma, promote access to care, and communicate the possibility of recovery, the first objective is to launch a public awareness campaign. Metrics for this objective will be developed with the goal of launching a public awareness campaign, conducting a statewide survey on stigma, trust, understanding, and support. And develop a behavioral health index as a second objective. We will, in addition to tracking key indicators by county, and behavioral health index will be developed to compare peer counties, states, and nations. A global behavioral health index that is recognized as being of the highest quality is the goal. And then a third objective is to promote understanding of the progress that has been made and advocacy that will result in further improvement through messaging and strategies. And the final goal is to strengthen the capabilities and processes of the Commission. Establish the Commission as an employer of choice that attracts and retains a higher performing workforce that reflects California's diverse communities. A first objective, the commission will the commission seeks to become an employer of choice that attracts and retains people who reflect the diversity of California communities. Having a diverse workforce at the commission will not only promotes inclusion and representation, but it also brings a wide range of perspectives, ideas, and experiences to the table. This diversity can lead to more innovative solutions, enhanced problem-solving abilities, and deeper understanding of the needs and challenges faced by California's diverse communities. The second objective is to ensure that IT performance meets or exceeds state and national standards. This objective will be achieved by regularly monitoring and assessing IT performance and ensuring that any issues are promptly addressed and resolved. A system of regular feedback and review will also be implemented to ensure that standards are being met. And finally, training will be provided to ensure that all staff are up to date with the latest IT technologies. A third objective is to adopt and implement best practices in fiscal transparency. Adopting practices in fiscal transparency can lead to increased accountability and trust. By being transparent in fiscal transactions and procurement processes, the Commission can demonstrate its commitment to integrity and ethical practices. This can build public confidence in the Commission's operations and ensure that taxpayer funds are being used effectively and efficiently. Developing communication strategies is the fourth objective. Public confidence in the Commission's operations is crucial for its success and effectiveness. When the public has trust and confidence in the Commission, they are more likely to engage with its initiatives, provide valuable feedback, and support its goals. This trust also helps to establish the Commission as a credible and reliable institution, which is essential for attracting partnerships, funding, and collaboration with other organizations. As a result, public confidence in the Commission's operations is essential for achieving its mission and making a positive impact on California's diverse communities. And then the final, as part of the fifth objective, we are committed to supporting the engagement of commissioners. It is our intention to provide the Commission with a better understanding of our portfolio and provide opportunities for us to engage with you and to create more efficient onboarding process for you. And that concludes my presentation, and wanted to really focus on some of the questions that were laid out, and as you know, as we kind of just reviewed what our metrics will be and think through how we can really meet our goals. It's really important for us to engage with with the Commission and the public to really see how we do this and how we do this well, because we don't want this to be a strategic plan that will be on a shelf. We want to make sure that we are moving towards our goals and able to reach our goals at the end of this 4 years. And so would be happy to hear from commissioners on any thoughts regarding our plan.
Commissioner Gordon, please.
Yeah, I just had a suggestion, a small suggestion, which is I think we should elevate the work that we've done to listen to youth voice, because that's a major part of our clientele, and I think the Commission's done a really good job of bringing forth and continues to expand that, bringing forth youth voice, and I think that will be more and more important as we go forward.
Great, thank you. Yeah, I'd like to second that.
Get some of that in here, okay, in the shorter version.
Great, thank you. Yeah, but I mean, I think, as you put these questions forward, I would like to get responses to, the decision-making framework, the community mental health. I'd like to see the responses from youth to any one of these questions, right? The capacity building, substance use disorder integration. I mean, we're continuing to see that more and more with our youth. So what are some of their answers to this? That would be important. So thank you, Commissioner Gordon. Commissioner Carnevale, Commissioner Rolette, and then Commissioner Chambers.
Thank you, and thanks, Norma, for the summary. A few suggestions. One is, we don't want this strategic plan to be floating on an island. We want it to be a dynamic, connected part of our work, right? And so I think what would be helpful would be to create a map that maps all of our initiatives against this, so it shows the coverage and it shows the gaps and it shows if there are things we're doing which are outside the boundaries of this strategic plan. That's what you want to plan to do. So that would be one recommendation, which will help us better track this. So then we see, for example, that youth was not really identified enough in the plan or whatever. I think it also, in context of the long conversation we had today about outcome contracting, I think we should be modeling that behavior. So we should be, the next step is to take this to some outcomes and not just impact, not just transactionally we're working in these directions, but, to figure out what quantification means and what's a good job, what isn't a good job, not just sort of generally moving in some direction, even though we're not, technically always responsible for delivering the end goals. I think that there may be ways there's always a way to quantify something if you're creative about it. So I would recommend that we, as a commission, move in that direction too.
Thank you, Commissioner Carnevale. Commissioner Rolette, please.
So I like what the hope is in accomplishing the executive summary what you hope to accomplish with the executive summary document. I do think that additional feedback as it relates to question 8, and I don't know how many, for example, if there's been a broad dissemination of the questions that I have in front of me and the other commissioners have, but I'll just, public trust and ownership, what strategies should the commission employ to build public trust and ownership in the mental health system? And what I often hear articulated online is that the commission is a place where there is indeed a sentiment about public trust, and typically it's very high. And given that that is an expectation that the public has of the commission, how do you quantify that in a strategic plan? Because again, you don't want a strategic plan to just be transactional. You want it to be slightly relational. And so how do you better engage the public in understanding and appreciating the value of a strategic plan? That's part of building public trust. This document could be a vehicle in which you might operationally try to do that. But I think that a deliberate exercise to address question 8 in developing a bridge between the commission and the public, not developing, acknowledging the bridge of trust that has been built between the commission and the public, because the public says that about the commission. They trust us, and it's important to them that we be here. That said, the be here relates to the BHSA, and while the plan was developed prior to the passage of the BHSA, I do think you should reference the BHSA, because not referencing it seems just sort of odd to me. And so as I was glancing through, I looked at this document. I really like this, by the way, and what it's trying to accomplish. I didn't see a reference to the BHSA, and I think that it's a noteworthy omission, and so you might want to think about that.
Okay. Thank you, Commissioner Rolette. Commissioner Chambers and then Commissioner Danovich.
Just want to thank you, Norma, for your work. And just to echo some of Commissioner Rolette's points on the public trust, I think it came up in committee as well. And just for the record of thinking, I know this is cliche, thinking outside the box, but I wrote down going into different spaces, uncomfortable spaces, comfortable spaces that we've not been in, non-traditional spaces. I don't know. I just think that, like Commissioner Rolette said, that there's so much trust in the commission, and how do we get that to other people and provide hope? Because I think on the ground level, I gave the example in committee of a monolingual mother at the jail crying, son